Woo. Welcome back, everyone, and thank you for being on time. If you are joining us for the first time today, we have a full afternoon planned for you that includes polling and session evaluations. I do have a couple announcements, one of which is we have printed packets of the presentations out at the table outside of the auditorium. So if you need copies of those, please go out and ask for one. My second announcement is there was a wallet found in the ladies' room, so if you are missing your wallet, again, please go out to the table that's outside of the auditorium. And my third announcement, actually, I should probably stop numbering them because I have a few, is that there is a black Amazon cell phone that was found, and that is at security. So if you lost your wallet or if you lost your cell phone, we do have it. Also, for those of you who are joining us for the first time today, if you we suggest that you use an Ethernet connection instead of Wi-Fi, and we also suggest that you connect via Google Chrome instead of Internet Explorer or Firefox to increase the webcast streaming speed and prevent delays. Also, for those who may be joining us, we are featuring interactive polling and session evaluations. So if you have not joined with us earlier today, please take a look at the information that was sent to you and that is posted on the website. There is a one-pager on how to join the polling sessions. And lastly, if you have questions for our presenters and you are in our viewing audience, please use the SurveyMonkey link to send in your questions, and then they will be addressed later on today during the open Q&A session. I am happy to introduce our next speakers who will provide information related to the online provider directory review, including methodology, findings, and common issues identified. From the Division of Surveillance, Compliance, and Marketing, please help me welcome Jeremy Willard and Christine Reinhard.
Appreciate it. We're really, everybody hear me okay?
Yep.
How about now? All right. I'll try to keep it a good distance here. I appreciate you going over what we're covering today. That kind of saves me a couple of breaths. And Christine and I have a lot to share, and we're going to dive right in. Before I get into the actual content of the presentation, I want everyone to, as we go through, to think about the tools that you use on a daily basis, how those tools are used. And when I was putting this slide together, Google Maps was the very first thing that came to my mind. I rely on it heavily, and I'm sure many of us do when going to airports, traveling all around. And I want you to think to yourself, as we're working through this presentation, what would you think if Google Maps got you to the right location 60% of the time? The other 40% might get you close, might get you a couple hundred miles away. It's a little iffy. And you got to think to yourself, what would you think of Google as a service, as a brand, as a company? And I want everybody to kind of have that in their mind as we go through today, just to see how critical it is for accurate provider directories. Now, at its root, provider directories are a simple tool, a tool used to connect beneficiaries and their caregivers to your contracted providers so that they can get the care that they need. The accuracy of that information is paramount for that happening. If any of that information is wrong, they're not able to get to that contracted provider. I don't think I have to spend a lot of time on our current environment. I was here last year, same time. We talked a lot about the types of things that we're seeing in the media, in previous directory reviews that we've conducted, also beneficiary complaints, congressional inquiries, so on and so forth. So this continues to drive CMS. This continues to prompt us to look deeper and deeper into online directories to see how accurate they are. I feel like my dad with the clicker. So it's important as we go through today's presentation to keep in mind that there are two distinct phases to our directory reviews. And you'll have to forgive me, I'll constantly say directory review, I'm referring to the online directory reviews. Phase one is 99% of what we'll be talking about today. It's the initial review, it's making the phone calls, it's providing analysis to what's on your online provider directories. Phase two is a verification review. That comes after phase one, making sure that any errors that we identify are corrected. Now, as far as our methodology goes, we have 54 parent organizations that we selected for this year's review. One contract for each parent organization, 108 providers, evenly split between 4 provider types for each of those 54 parent organizations. And then we reviewed every location for each of those 108 providers. So if you think about it, starting with the 108, it was typical that that would result in 150, 200, 250 different locations for those 108 providers, and resulting in a lot of phone calls, as Christine's going to talk about. I mentioned that we focused on 4 different provider types. Those were primary care physicians, oncologists, ophthalmologists, and cardiologists. They were selected because they were of the higher utilized provider types for both fee-for-service and Medicare Advantage. As far as the selection, wondering how we selected the parent organizations, it was a combination. So we looked at enrollment, meaning high, those organizations with a high enrollment number. An audit, meaning if those organizations were up for audit in that given year, last year, as well as random sample. Each of those together combined to be the 54. We then randomly selected the contract one contract under each parent organization, randomly selected the PDP, as well as randomly selecting the county or zip code. When we did so, there was a mix of urban versus rural. That came down by each parent organization. So you were either one or the other. We either looked at your rural offerings or your urban offerings. And then as far as the provider selection, we used a skip level method where we would look at the online directory, select the providers by picking one every 5 or something to that effect. to provide for a random aspect of it. As far as the elements reviewed go, I've gotten a lot of questions about this, and I think that some folks were really thinking into it maybe a little too much. Really, what we did is we looked at our model provider directory, the various data elements that are required in the model directory, and that's what we called and reviewed based on. Those included the provider name, NPI, provider specialty, practice name, does the provider work at the location, does the provider accept the plan at the location, street address including the suite number, provider accepting or not accepting new patients in general, as well as phone number. Those were the data elements that we reviewed. Now, some important things to remember when we're talking about this. CMS was very transparent in how we conducted these reviews. This was not done via secret shopping or anything like that. We didn't pose as beneficiaries. We had a contractor, Booz Allen Hamilton, who conducted all of these phone calls. And when Booz Allen Hamilton called, they explained who they were calling on behalf of, and they were also at the ready for any kind of documentation should the provider have any questions. So if the provider thought, is this really on behalf of CMS, we had faxes, emails, letters that were ready on our letterhead that they could share. And that part's important to note. If you hear any of your contracted providers saying that CMS called and wanted to get beneficiary information, PHI or something like that, you can let them know that that's not us. And we did communicate this with the provider community. Now, while I say our review was transparent, we did have a beneficiary focus. And I guess boiling it down to its most simplest terms, it was making sure that if I were to call that entry, that location for that provider in the directory, would I be able to make an appointment at that location? And was that information correct? The review process itself, and again, this is the phase one. As I mentioned, we had Booz Allen Hamilton. They made the calls for each provider, so for each organization, the 108 providers. They attempted to check all information by the first call. So if the provider had 5 locations, they would call the first location in the directory, and they would look to verify all information if that person was feeling equipped to be able to answer that question. And they did check with the person that answered the phone. They didn't just kind of go into their script. They said, are you someone that's comfortable answering the questions that we have to ask? They would work their way down, hopefully answering all the questions to minimize the number of calls to providers. If they were unable to do so in the first call, they would just work their way down until all locations were resolved, meaning we got the information we needed for all of those locations. As I mentioned, it was a script, so each one was done as close as possible to one another. That information is then provided back to CMS. It's provided on a very, very big spreadsheet. And if you think of the spreadsheet, line by provider location, column by all the data elements that we collect. We review that. We identify the deficiencies. And then those deficiencies are shared with the parent organization. They're shared via that same spreadsheet. We make some tweaks to the spreadsheet, but by and large, it's the same. And it's important to note that if you, again, think of the lines and the columns, anytime there's an instance where we find something wrong, we highlight that in yellow. So the errors really pop out to that plan that's receiving that information. In addition, we've dropped additional columns to the right of all of the data, one of which says deficiencies yes or no, so that you can filter just on seeing where are our deficiencies to give you an idea of what's wrong and what's right, as well as another column that talks about how many deficiencies for each location. And the importance of that will come into play here in a subsequent slide. The parent organizations are provided this spreadsheet. We typically have a 15-minute phone call with each parent organization, as well as detailed instructions provided via email. And really explaining this is what we're looking for, this is what we're looking for response-wise. And they're given 2 weeks to respond. And as far as what the responses are, for each location, if you think of the spreadsheet again, they're asked to either concur, meaning they agree with the finding or findings, non-concur, meaning they disagree, and then they have a section to provide additional information, or both. And the both would come into play if you think about it, those various data elements. There may be 3 errors identified with a location. They may agree with 1 and not 2. So we agree that the phone number is wrong, but we disagree that the address is wrong. After the 2-week period, CMS receives the spreadsheet back The plan populates it with their concurs, non-concurs, and their supporting documentation. And then we review and make a final determination. In an upcoming slide, I'm going to talk about in a little more depth as far as what we do to make that final determination. But we make additional phone calls, we review the data, we compare what our contractor found versus what the plan's saying, and we make a final determination. That final determination is submitted to the parent organization, and then they are given 30 calendar days to make any needed updates. So if a provider shouldn't be in the directory, they remove it from the online directory, remove that provider. If something's wrong, they correct that within 30 days. Now, in the beginning, I talked a little bit about phase 2 being 1% of this presentation. Here's our 1% slide. After all of that is done, and no sooner than 30 days, phase 2 goes into effect, and that's when we review or validate that the directory has been properly updated. And in addition to the directory, when applicable, we are also looking at HSD tables to see if providers have been removed appropriately. I'm now going to switch gears just a little bit to talk about some common problems we're seeing with plan responses. And this would be focused on the non-concurs that I had talked about as far as when reviewing the data. The first is a failure to provide an adequate review or response to the data. And I would sum this up by saying some organizations have what I would call blind faith in their source data. So we would provide an error, and instead of maybe making a phone call or doing additional research, they would look at the source. That may be credentialing, that may be a third party, and they would, the phone number's wrong, and they would look at their source data and they would say, nope, that's the phone number we have, and they would non-concur and cite, credentialing said it's correct, or our source data said it's correct. Our expectation is that plans put their best foot forward as far as reviewing the data. We really want you to, do what's necessary to hear from the provider themselves, get solid responses as far as if you are disagreeing with us. The next is a failure to respond to all identified errors. And again, if you think of my example of having multiple errors, and this may be an example of when you would put both as far as agreeing with some, not agreeing with others, we've seen a number of organizations who will non-concur or hit both, and they will provide detailed data, but only on one error. And this is where that column of number of errors really comes into play. If you're in your compliance department and you're reviewing this data before it's sent to CMS, you want to just look, filter based on the numbers, compare those numbers to what the responses are, and they should match one another. Oops. The next is failure to actually verify the information. And I would sum this up to kind of a cut and paste approach to responding. And you may have 20 errors and there's the same answer for each of the 20, which again, by itself doesn't necessarily mean that it's wrong. But what we had found is of those 20, the narrative corresponds to maybe 15 or 12, and then the narrative mismatches with some of the others. So it seems as though it's kind of a rush to response maybe. We also see some, what I would consider to be like a simple thing to check, such as a phone number not working. And so our contractor finds that a phone number is disconnected, the plan non-concurs and says the phone number is good. And again, I think this gets back to checking the source data. When that happens, Christine and I pick up the phone and we call, and more times than not, the phone number is disconnected. And that's something that, in my mind, should be an easy thing to double check. The last point here, and I think this is the most important in my mind, and I think one that we can easily fix, and that is in our communications with group practices, educating those group practices so that they know we need the data at the provider level, not at the location level. We've seen time and time again with responses where group administrators or folks that are responsible for group practices are really focused on the location, not on the provider. So a great example would be, we might have Dr. Smith, and Dr. Smith is listed in your directory 5 times. And we make phone calls, and 2 of those, the office answers and they say, yeah, Dr. Smith practices here. The other 3, oh, we're sorry, Dr. Smith is in this group practice, but they don't practice at this location. We provide that finding to the plan, and then the plan reaches out to their group practice administrator responsible for that provider or that group. And the group, I think, looks at the information and they say, no, we're there. And then they provide that back to the plan, and the plan gives that to us in the form of a non-concur. And I would say at a very high level, we find that what our contractor initially found is what it actually is. And we do that, and again, I'll be talking about it here in a minute, but with additional phone calls. And so what's happening is the group practice is really focused on where they are, not who is there. And I think we really need to do a better job as an industry to educate group practices that the expectation of having a doctor listed in a directory at a location is that a beneficiary can call and make an appointment for that doctor at that location. And we saw and I don't want to steal Christine's thunder, but we saw a high number of instances where the provider was not at the location. Have the next slide, please. Now, getting back to, I alluded to this a little bit, data validation. I want you all to know that we take the the response validation very seriously. I don't want anyone in this room or watching online to think that we immediately side with our contractor. When a plan non-concurs, and we design this process to allow for that voice, to allow for plans to non-concur, because we know how this data is, and we know that it's not 100%, and we want to make sure that it's 100%. So that's why we have this give and take as far as allowing for non-concur, concur in both as far as a response goes. And when we do receive the non-concurs, then it kind of switches from contractor work to internal CMS work. And for this past year, Christine and I and our team that we work with, we've made probably thousands of phone calls following up on non-concurs to check our contractors' work. And we don't just blindly accept the answer. We're not, trying to quickly get to an answer. It's taken quite a lot of time, but it's really important to us that we get this right. And we make the phone calls and we reach out and we see ourselves almost as a tiebreaker. So you have our contractor saying there's a problem, you have the plan saying there's not a problem and here's why. And so we make the phone calls as needed to determine what the final answer is. And I do not want to dissuade anyone from submitting non-concurs, but I would say, and this is especially the case for instances where the provider is listed as not, or is found to be not practicing at a location, our contractor versus the plan's non-concur, we have found that through our follow-up phone calls, 90 to 95% of the time, it's showing that the contractor was right versus what the plan is providing. And I think, again, some of that is based on the fact that it's source data, it's group practices providing information, but I just would want to keep that in mind. And again, thinking with my compliance hat on, if I worked in a compliance department and I were reviewing data before it's being sent to CMS, if you see a high level of non-concurs, that doesn't mean that that's not possible, but I would look at it with a critical eye, especially given the information that I'm providing today. Now, switching to the positive, I want to talk about some lessons learned and some helpful suggestions. And the way I kind of think about this, and again, putting on my compliance hat or my plan hat, when we were writing these slides, it's like, how would I approach this if I were working at a plan? What are some things that I would look at? The first is just the interface of the directory itself. How friendly is it to the beneficiary? We see instances where plans have a core platform that is kind of pulling multiple products together as far as showing the providers associated with that network. Not a problem at all, but you want to make sure that it's clear when you do that. You want to make sure that if you're a Medicare beneficiary, it's very clear what providers you're looking at. The next is to make sure that providers are only listed one time at each location. And I look at this as, again, another kind of low-lying fruit type of thing, and the message or the takeaway is scrub your data. We saw countless instances when a provider was listed again 5 times. 5 times at the same location, each location spelled slightly differently. So the reality of that is 4 of those 5 are wrong, and 1 is correct. And I don't think it would be too difficult to do a query to pull out similar addresses and things like that. Providers might have moved next door, they may have, changed a phone number or something like that. And instead of that old entry being removed, we see kind of the snowball effect of things are added, but they're not taken away. Next slide, please. The next one, again, low-lying fruit-wise, is review the number of locations at each provider, for each provider, I'm sorry. And this is another one which was a big takeaway for us. In reviewing the findings, if you have a provider listed 6 or more times, the chances of one of those listings being incorrect is 80 to 90% based on our reviews. And so, again, it's not impossible that a provider has multiple locations. We've saw providers that had 16 locations and they were all perfectly fine. But if I were at a plan and I were looking for problems and looking to determine how things are going or looking for just a starting point, I think doing a query of my provider database for instances where a provider is listed 6 or more times is a great starting point to determine how accurate that information is. And in the kind of same vein, auditing the data. As I mentioned before, we saw lots of instances where there was this blind faith in source data. And I think it would be very helpful, just like any other operation that takes place within your health plan, to do internal audits, to review the data. And as you know, when Christine gets into the content of the actual findings themselves, I think you'll find that it would not take many phone calls to determine how good or bad your data is. Verify provider locations based on individual versus the group practice. I spent quite a lot of time talking about that, but I would want to reiterate it. We really need to educate group practices as far as how they're providing information to plans. Claims data is the next point. I'm a big fan of claims data. I've had many conversations with organizations where I've touted claims data as being a good source of information, but I want to make sure I temper that by saying it's not the end-all be-all. Claims data has limitations. Sometimes it doesn't give the full picture. And I think that's some of the struggle that we see with this. There is no silver bullet data source that you can look at that's going to give you 100% accuracy. So you kind of have to use a blended approach based on the situation, the provider type you're looking at. And so claims data is great. Claims data shouldn't be the only thing. The next two are just kind of from how the directories put together. Listing providers once they're active or notating it. We saw lots of instances where we would call a provider and they would say, well, the provider's here and everything's right, but they're not really, the contract's not active until 6 months from now. And there's nothing wrong with having that provider listed in the directory ahead of time, but you should notate that effective 1/1/17 or something to that effect. Because again, you're setting an expectation for a beneficiary that they can connect with that provider and make an appointment with them, and you're creating kind of a dead end based on that later start date. And the final point here is notating providers that see only a subset of members. And what I mean by that is you have membership to the plan as being like your initial hurdle to getting access to that network. We see instances where providers have additional hurdles. And I think the greatest, maybe for a little comic relief example that I could think of is we had a health plan we reviewed and there was a provider listed as a PCP and they worked at a university health center. And so if you were a member of the plan and you were enrolled in that university, you could see that provider as a contracted provider. But unless those two things were met, you didn't have access to that provider. So it's just critical that if there are additional hurdles, and this one was very uncommon, but we do see certain things, Indian Health Service and stuff like that, that there are additional barriers. And our expectation would be that it's fine to list them in the directory, but please note when those barriers exist. Oops. Can we go back one, please? As far as future policy decisions go, I'll be very high level on this and very brief because I really know that everybody's looking forward to what Christine has to say. But some of the things we're looking at and trying to get our arms around, and we would be very interested in hearing your feedback, is providers that don't necessarily have a one-to-one relationship with beneficiaries, meaning you can't just look up the provider and call and make an appointment with them. Hospitalist is the first thing that comes to mind. Even though there's not that direct relationship, we did see some of those providers listed for certain specialties, but if you called for that specialty, you were unable to make an appointment with that doctor. And a great example would be instances where a primary care physician was listed at a location that turned out to be an urgent care. And that, again, I mean, that doctor practicing in that capacity is certainly fine, but it's not, when they're in that capacity, they're not in the capacity of a primary care physician in the sense that it's your family doctor and you're calling and making an appointment. So those are some of the things that we're kind of starting to get our hands around, doing further analysis as far as the directories go. So with that, I'm going to turn it over to Christine. She's got a lot of really interesting information to share with us.
Thanks, Jeremy. And can everyone hear me okay? Okay, great. Jeremy, with high level, went over how many organizations we reviewed. This past year, again, we reviewed 54 parent organizations. We reviewed 108 providers for each parent organization, split as equally as we could among the 4 specialists, the PCPs, oncologists, ophthalmologists, and cardiologists. It totaled 5,832 providers that were contacted. That was a little under 6,000 calls that our contractor made. That does not include the additional follow-up calls that Jeremy, I, and other members of our team made following initial findings. That accounted for 11,646 locations being reviewed for those 5,800 providers. Here is our, oh no. I hope you didn't look. Okay, here's our first little quiz. I'd love everybody to take a look. Hopefully you didn't see too much of the data or didn't read too quickly. Out of all the locations we looked at, curious as to know what you think the percentage of locations that had inaccuracies were. Okay, it looks like we've got some stability here. Yeah. I think you saw the next slide. Technology works great, but not perfect. So a lot of you guys are saying 45 to 60%, and you are on the mark right there. As soon as I can get this thing to work. Next slide, please. Okay, so we had 5,257 locations with deficiencies. That accounted for almost 46% of all those locations had one or more items wrong with them. The total number of deficiencies were 5,352 deficiencies. Some locations had more than one deficiency. It may have had the phone number incorrect and the address incorrect, or it may have had the provider not seeing patients when they were, as well as maybe the suite number. It is important to note, Jeremy mentioned that we did look at practice names. Following the review of the initial findings, we decided to exclude practice names from the final deficiencies. So there were hundreds, if not thousands, of inaccurate practice names we looked at, and there were a variety of reasons that we excluded that. One is that we don't have firm requirements in our directory on exactly what we mean by practice name. The other is that the practice names, there were nuances where you might have 3 or 4 names listed, and when we made the call, there may have been only 2 or 3 names that the practice name went by. Some organizations had the practice name listed as the contracting entity, whereas when our phone call was made, they notified that the practice name was listed as Willard and Associates. So for various reasons, we did exclude that. Next slide, please. Out of the 54 organizations, we have a slide here showing exactly the percentages of inaccuracies that were the final deficiencies for organizations. Taking a look at this, we had 2 organizations that did quite well. Between 0 and 10% of their directory was inaccurate. No organization scored between 10.1 and 20%. The majority of our organizations scored between 30.1 and 40% of their online directory. Of the 108 providers and the locations, there was at least one inaccuracy, if not more. So we've got a real concentration between really between 20% and between 60%. We had a couple of outliers. Our highest, just to let you know, our lowest inaccuracy rate was, I believe, was 1.77%. Our highest inaccuracy rate was almost 87%. So there was a wide range with the majority of plans falling in that middle section. Okay. Deficiencies. Jeremy mentioned all the items that we looked at. We made final determinations on which of those items were deficient. And we'd like to do a quick polling and for you to tell us what you think was the most deficient item. I love how it just moves back and forth and it finally stabilizes. It keeps me questioning too. I am on the edge of my seat. Okay, it's looking like we've got a great set of answers there. Okay, feel like a little bit of David Letterman, top 5, not top 10, but top 5. Next slide, please. Okay, number 5 was the address suite number. It occurred 221 times for about 4% of all deficiencies. Not big. Most of these, they were small changes on suite address, suite numbers. When we take a look at this for address, important to note, we did separate address from suite number. To CMS, there was a significant difference when the address was 123 Main Street versus 456 West Street. That's a much more egregious and much more problematic issue than when you have suite address, then the suite is suite 101 instead of 102. You can get to the building, you have to go to a different room versus Google Maps taking you completely to the wrong building. So that was our 5th most number 5. Okay. Number 4, providers not accepting new patients, 338 times, a little over 6%. We recognize that provider not accepting new patients and provider accepting new patients can be a fluid item in the directory. When we did look at this, we were pretty lenient on those deficiencies because providers do change possibly month to month, time to time. So that is one of the areas that is a little bit more difficult to keep up to date at the exact time of the phone call. Number 3 is address. Again, this is a little bit different, as I mentioned, different from the suite address. The actual address is incorrect. There had to be corrections made to that, 123 Main Street versus 456 West Street, 450 times, 8% of the deficiencies. Number 2, and we're going to get number 2, phone number, 521 times, not almost 10% of deficiencies. What is really interesting is a lot of these phone number inaccuracies, they were disconnected phone numbers. When you can't get the right phone number, you cannot make an appointment with your provider. We had phone calls that went to providers' personal cell phone numbers. We had emergency rooms. We had other businesses. And I think we had a few calls that actually went to beneficiaries. I don't know how those numbers got in there and went to individual people, but please make sure the phone numbers are correct. The vast majority of them were disconnected or out of service phone numbers. And most people got this right. There's no drum roll because you guys got this all right. The number 1 deficiency we had was the provider was not at that location. It occurred 3,544 times, 66.2% of all deficiencies. This was not what Jeremy and I expected when we undertook this project. From the beginning, we were expecting more items like address, suite number. We were not expecting to find so many providers that weren't even at their location. We had providers that had been retired for years still in the directory. We had providers that had passed away. over a year ago or more, we had a lot of provider practices that said, I don't even know who this person is. He or she has never worked here. So that was a surprise to us. It was either a surprise to you or it wasn't a surprise to you. You may have gotten the data. I'm not sure. The Google Maps may have given you a little key that this number was pretty high. Okay. Oh, darn it. I'm not very good with this clicker. Okay, can we go back one? Okay. Do you think there's a significant difference in accuracy based on provider specialty? Now remember, we did the cardiologists, oncologists, PCPs, and ophthalmologists. Okay, so stop. I know, it keeps moving the numbers. Next slide, please. We found, and again, statistically, I think you can make some arguments. You can make arguments that aren't statistically significant. I'm not going to get into that. Ophthalmology, as you can see, was much lower than the other practices. Primary care, oncology, and cardiology were all about the same or close. Ophthalmology was lower. We're not saying that the ophthalmology online directories were more. Overall, we're not. If you're going to focus, what I'm trying to say is if you're going to focus on certain areas, the cardiology, oncology, primary care, from our review of 5,800 providers, did a little worse than ophthalmology. Clearly, though, ophthalmologists are not, their accuracy is a problem in ophthalmology, too. What is interesting, though, is the number of locations that were looked at. When we look at cardiology and ophthalmology, we had relatively close, 600, difference of 600. We've got a 17, almost 18% difference in the percentage of locations that have inaccuracies. So, as Jeremy mentioned, I think it's really important to take a look at the number of locations you have for some of these providers. We had significantly more locations for cardiology. Next slide. Okay. Is there a significant difference based on county density? Jeremy mentioned we looked at urban plans and rural plans. We then broke out the providers into the 5 different counties: macro, micro, CEAC, metro, and there was one more. That's on the next slide. And we'll give that just another few seconds to... Okay. It looks like that's pretty stable. Next slide, please. That breakout, surprisingly, they're all in the same, within 10 percentage points of each other, actually a little bit less than that. We were wondering if there was going to be large differences between the more urban and the more rural settings, and there are not significantly large differences between these. There could be a number of reasons that there are different inaccuracy rates. It's something to consider, something to look at, but at this point, I don't think we're making any real determinations on whether or not they score better or not. We, again, looked at a lot fewer locations for the CEAC and the rural areas. Our concentration, because we looked at a greater percentage of urban plans, and there were a lot more providers in those urban plans, there are a lot more locations, so there's a larger universe to look at. Going through a few of the CMS concerns is the excessive number of providers not at that locations. That is a big concern. Looking at the number of those deficiencies that we had. Providers that aren't working there should not be listed in the directory. We also had a big concern with providers not aware they're contracted with the PO. This came into account where the provider worked at the location, but the provider said, we don't actually take that plan. In one case, we had an organization that the plan expanded in 2014, and the providers still weren't aware of their contracting status. And this, these calls were made in mid-2016. So especially when you expand or add providers to your network, please make sure you educate those providers about the acceptance of your plan. Implications on network adequacy. When we did this review, we also asked organizations, do you use the same underlying database for your online provider directory as you do for your HSD tables? The majority of plans do. With so many providers not being where they're listed, we are concerned that that's going to have an effect on HSD tables. Now, given that a provider may practice at 5 locations and 4 of them are correct and 1 is incorrect, that's going to have less of an effect versus a provider that's listed at 10 locations and 8 of them are incorrect and the provider's not actually there. So it's something to consider and be aware of. Next slide, please. Food for thought. After looking at a review, if a beneficiary of yours picks a provider from the online directory, there's a 46% chance something's going to be wrong with that. There's a 30% chance of the provider not being at that location. So 3 out of 10 providers that they pick, they won't be able to make an appointment with because the provider does not exist at that location. Next slide, please. Compliance approach. We are still working on the compliance for this year's provider directory analysis. We intentionally waited until all parent organizations were reviewed. We have and are weighting the deficiencies based on egregiousness. Provider not even being at the location is certainly more problematic than a suite number being wrong. For this year, we are not, if there's more than one deficiency, we're not making a cumulative weighting. We're taking the most egregious deficiency and counting it as the weight of that most egregious and not adding up the other deficiencies. And as a note, compliance actions can come result of phase 1 or phase 2. And again, we're still working on that. Challenges. We know there are challenges. There's no question. We've had many conversations with organizations. We've heard about some of the challenges from these organizations. We've listened to conference calls. We understand. We've read the articles. We understand the challenges. But given the importance of the directory, the accuracy's got to improve. It's got to improve. We understand there are going to be no provider directory is going to be perfect 100% of the time, every single day. But a 46% inaccuracy rate is just not acceptable at any time. Next review cycle. We're going to review again about 54 organizations, give or take a few. The review will begin within the next, I'd say, 2 to 4 weeks. We're going to look at the same provider types again this year. Next slide. And I think that was, and we have 17 seconds for questions.
Oh, actually, we are out of time, so if you do have questions, please hold them until the end of the day during the open Q&A session, and we will address them at that time. So right now, I'd like to thank Jeremy and Christine for sharing with us today. If you would like to evaluate this session, go ahead and take out your phones and text your response in, or go to the Poll EV link on your iPad, phone, computer, or tablet, and enter A in response to the question, I would like to evaluate this session, and then go ahead and complete the evaluation. Also, I have one more announcement, and that is that a black portfolio was found in the women's restroom. So if you are missing your portfolio and you are a woman, you can check with the table outside the door. Up next is a panel of speakers who will share an overview of the work that CMS is conducting related to developing care coordination measures for Medicare Advantage and special needs plans. During this presentation, the importance of care coordination, potential measures currently undergoing development, and how they support CMS quality strategy goals will be discussed. It is my pleasure to introduce to you Donna Williams, Susan Radke, Sarah Peterson, and Erin Giovanetti. And next slide, please.
Good afternoon. It's great to see you all here, and those who are viewing on YouTube, thank you for joining us this afternoon. I'm Susan Radke, and I work in the Division of Policy Analysis and Planning. I am the Contracting Officer Representative, or what we call CORE, here at CMS, and I am the CORE for 2 contracts. They both focus on developing care coordination quality measures for Medicare Advantage. Next slide, please. Our session today is going to provide you with a discussion on the definition of care coordination, our CMS 2016 quality strategy, our mission and goals. We will talk more about care coordination and Medicare Advantage and how we are developing these measures. NCQA will be talking about their current development measure work through HEDIS, and INPAC will discuss their measurement development work using Medicare Advantage encounter data. And with that, I'm going to pass it on to Donna.
Thank you, Susan. So we're going to go ahead and kick off this presentation with a polling question. And what I would like for our audience to do is tell me how you would define care coordination. Is it A, the deliberate organization of patient care activities between 2 or more participants, that includes the patient as well, involved in a patient's care to facilitate the appropriate delivery of health care? Is it B, organizing care that involves the marshaling of personnel and other resources needed to carry out all required patient care activities? Is it C, often managed by the exchange of information among participants responsible for different aspects of care? So I'll give you a little bit of time to answer this question. Okay, looks like the results are in, and if you said letter D, then you are consistent with AHRQ's definition for care coordination. AHRQ is the Agency for Healthcare Research and Quality, and we will be using this definition consistently throughout this discussion, as this is the basis for our measure development work. Next slide, please. The CMS quality strategy aligns with the 3 broad aims of the National Quality Strategy, or the NQS, and these are better care, smarter spending, and healthier people and communities. The mission of the CMS 2016 quality strategy is to optimize health outcomes by leading clinical quality improvement and health system transformation. To support our mission, CMS has developed these 6 quality strategy goals, which include make care safer by reducing harm caused in the delivery of care, strengthen person and family engagement as partners in their care. Number 3, which you'll see is highlighted, promote effective communication and care coordination, promote effective prevention and treatment of chronic diseases, as well as work with communities to promote best practices of healthy living and making care more affordable. For the purposes of this discussion, we will be focusing on quality strategy goal number 3. However, I do encourage everyone to visit the CMS website for more in-depth information on the CMS quality strategy, as well as the national quality strategy. Under goal number 3, the objectives include reducing admissions and readmissions, embedding best practices to enable successful transitions between all settings of care, and enabling effective healthcare system navigation. CMS aims to achieve these objectives by promoting increased care coordination across the healthcare continuum, promoting a person-centered approach to coordination of care, and recognizing the positive impact of having critical pieces of information communicated across all providers and healthcare settings. This begs the question, though, in the Medicare Advantage program, how will we know if we're achieving these objectives? Susan?
One way that we will know how we are increasing these objectives is to develop quantifiable care coordination measures. We alerted the healthcare industry, the Medicare Advantage healthcare industry, in our April 4th, 2012 call letter, described our efforts to expand the area of measuring care coordination. And we focused on our target population, identifying relative activities, and using various data sources. We are hoping that the measures will provide a comparative information, as we have here on our slide, on care coordination services to provide this care coordination to Medicare Advantage beneficiaries and MA plans. Next slide. CMS has awarded 2 contracts to develop care coordination measures for Medicare Advantage. Our 2 contractors conducted targeted research, extensive literature reviews, and data analysis, and engaged in discussions with expert panels and high-performing plans. Our next speaker is Erin from NCQA, who will provide more detail on the work that they're currently doing under our contract with CMS. As stated before, NCQA is coming from the viewpoint of developing care coordination measures through HEDIS. And then after Erin speaks, we will hear from Sarah from IMPACT, whose work is to develop care coordination measures from a Medicare Advantage encounter data. So Erin, thank you.
Thank you so much, Susan, and thank you for inviting me to come here and speak today, as well as for CMS's support as we work towards developing these really critical quality measures. So I think this is probably known to everyone in the room, and Donna spoke to it earlier, but when there is a lack of care coordination, this can lead to many negative outcomes, including duplicated services, medical errors, medical crises, and even avoidable hospitalizations and emergency department visits. And these type of errors can then lead to worse outcomes in individuals, higher costs, and worse patient experience, which overall is low-value health care. We see that Medicare Advantage plans have a unique opportunity to actually improve the quality of care coordination, particularly for older adults. As adults age and develop more chronic conditions, the number of providers they see increases. A study of Medicare beneficiaries found that the median number of providers Medicare beneficiaries see in a year is 7, and that includes 2 primary care providers and 4 specialists in a year. And often these providers work in silos, not communicating with one another. You can see this in many areas where effective collaboration between a primary care provider and a specialist may actually lead to better care and care that's organized around an individual's goals, but there's very little communication between these providers. And it's often the role of the patient or the patient's family to play the connection between all the different providers. So Medicare Advantage plans are in a unique position to see the whole person's care. As a payer of this care, they can actually see the care that's being provided in all these different settings and provide the systems and incentives to encourage care coordination. So to identify new measures for care coordination, we started with the ARC framework that Donna mentioned earlier. The ARC framework for care coordination identifies multiple domains that includes transitions of care, communication, assessment, and care planning. We then conducted a literature review in each one of those domains and did a measure mapping exercise where we identified where are there existing measures that could be used to address some of these domains. And one of the hardest parts about developing measures for care coordination is that many of the aspects of coordination do not lend themselves well to measurement. Much of care coordination, what is really good care coordination, is good communication between providers. And that communication is not always documented. We were aware that there are several efforts ongoing to collect information from beneficiaries directly about their experience of care coordination, both through the CAP survey as well as a survey being developed by ARC. So we focused our efforts on where we could have measures that were based off of clinical claims, medical records, and as well as health plan level data. We also conducted discussions with high-performing Medicare Advantage plans to identify what are some elements of good care coordination that we can measure. We brought all these findings to our care coordination expert work group, as well as our long-standing geriatric measurement advisory panel that advises on all HEDIS measures that are focused on the geriatric population, and our committee on performance measurement, which is the voting body that decides on HEDIS measurement. We identified a list of 17 measure concepts, and through work with our expert panel and discussions with Medicare Advantage plans, we narrowed this list down to 6 concepts for development. And where we really focused was what could be reliably, validly, and feasibly measured. So we really wanted to know where things were being documented that we could identify either through claims or through medical records or through health plan records. We also wanted to focus on populations that were at highest risk of not receiving good care coordination. So while everybody can benefit from care coordination, there are specific populations, particularly those with multiple chronic conditions, where the lack of good care coordination can lead to particularly disastrous outcomes. And finally, we wanted to keep an eye on how we could minimize data collection burden. We're very aware of the cost and resources that are necessary to collect information on quality measures, particularly when those quality measures are based off of a medical record or chart review, and we wanted to streamline this measurement as best as possible. So we identified, as I said, 6 measure concepts that fall into 2 groups. One is focused on transitions of care from the inpatient to outpatient setting, and the other is focused on patients with multiple chronic conditions. And I'm going to be going through all of those in the next few slides. So starting with transitions of care, we have one existing measure in HEDIS that is reported by Medicare Advantage plans focused on transitions of care, and this looks at medication reconciliation post-discharge for all discharges from Medicare Advantage plans. But we felt that this measure was incomplete in terms of telling about the quality across the whole continuum of the transition. And so we identified ways we could expand upon this measure to identify other critical elements within a transition where care coordination is necessary. So starting at the very beginning, one of the things we heard from our expert panels as well as from Medicare Advantage plans and providers we spoke to was the importance of providers being notified of an admission to the hospital. That is the first step in a provider being able to, number one, provide any particular care that might be necessary for someone in the hospital, to coordinate their care in the hospital, and most importantly, to be prepared to provide care for that individual when they leave the hospital. And while this may seem a very simple thing, it's actually something that is a critical gap in communication right now. Once someone's discharged, there are several pieces of information that need to come from the hospital and come back to the primary care provider. And this is often included in a summary of care record. And these include things such as test results and pending test results. In the transfer of this information from the hospital or other inpatient setting back to the outpatient care provider is critical to ensure that repeated tests are not done or that important test results are not missed. Now, throughout all of this, we wanted to make sure that there was actually a focus on how providers were engaging with patients in this process of transitions of care. And we wanted to identify whether or not there was engagement with the patient within 30 days of the discharge. And this could be included as a phone call, a visit in the office, or a home visit. And then finally, medication reconciliation, which is the existing HEDIS measure that looks at reconciliation of a discharge medication list and an outpatient medication list. The advantage of these measures is that they can all be identified from a single sample, which means it's not necessarily introducing a new sample of charts that need to be reviewed, but simply looking within a chart for additional information. So now is a polling question, just to get a sense from the audience of which measure do you think is most reflective of high quality care coordination. There's no right answer here. It's mostly just to get a sense of what people think is most important. Notification of inpatient admission, receipt of summary of care record, medication reconciliation post-discharge, or patient engagement after inpatient discharge. So there is a bit of a mix, but it seems like a lot of people think patient engagement after discharge is a critical step in care coordination, as well as receipt of the summary of care record. But I think what's most important is that none of these elements got 0 votes, meaning that these are, we feel, all critical components of transitional care. So next slide, please. So we tested these measures in 4 health plans and a sample of about 600 records. We actually piggybacked on 2 health plans that were collecting information on the medication reconciliation post-discharge measure to collect this additional information. And here you can see the average performance rates. And so this is looking at notification of inpatient admission within 1 day of admission, with an average rate of about 41% of discharges. And the range we saw was actually 4% in the lowest rated plan to 80% in the plan with the highest rate of notification. In terms of the receipt of the summary of care record, right here what you see is a rate looking simply at the receipt of the primary care provider receiving any piece of discharge information within 1 day of discharge. And 43% was the average rate, with a range of 3% to 80% across the plans. As we move forward with this measure and we start to add more elements of what is required to be in a summary of care record, you see this rate actually go down. Medication reconciliation post-discharge. This data actually comes from our first-year analysis of the HEDIS data. So this is the average performance across all Medicare Advantage plans, with an average of about 23% of discharges having a medication reconciliation documented within 30 days of discharge. And the range here was 0% in the worst performing plans up to 90% or 96% in the best performing plans. And then finally, patient engagement after inpatient discharge. This was actually tested in a sample of claims data of about 40 Medicare Advantage plans, a little under 500,000 discharges. And here we saw that on average, About 70% of discharges had some type of follow-up within at least 30 days, with a range of 55% to 82%. So we are actually next week bringing these measures to our committee for performance measurement with hope for approval to include in our public comment for HEDIS 2018. So these measures will be out for comment in hopefully February and March of 2017. Next slide, please. We also, though, we don't want to focus exclusively on transition of care. We want to identify patients who may be at risk of poor care coordination before they are hospitalized. And so here we're looking at a group of measures that would look at care coordination for beneficiaries with 3 or more chronic conditions. And our proposed measure concepts are comprehensive assessment of needs and goals, so an assessment that looks at core domains of health and wellness for individuals with chronic conditions, as well as their goals of care. A measure that looks at the specialist providing a visit summary to a primary care provider after a specialist visit. So this is really a measure trying to get at how do specialists communicate with primary care providers, and are they providing information back to primary care providers once they have visited with a patient. And then finally, a measure of follow-up after emergency department visit, once again for individuals with multiple chronic conditions. And this would look to see if individuals had a follow-up visit within 7 or 30 days of an emergency department discharge. Next slide. So same question again, which measure concept do you think is most reflective of high-quality care coordination? Comprehensive assessment of needs and goals, specialist provides visit summary to primary care provider, or follow-up after emergency department visit? So it may be that it's none of them above. Or it could be post-lunch and people just aren't interested in answering this question. So if we could move to the next slide. So just to give you a little sense of where we are with this, we've actually already conducted testing on the follow-up after emergency department visits, and I'm showing you here just one rate, which is the rate within 7 days for people with multiple chronic condition, and about 34% had a follow-up within that 7-day time frame. We're going to be moving into testing on the other 2 measures, comprehensive assessment. What we hope to do there is actually build this measure off of the existing care for older adults measure in HEDIS, and potentially streamline that measure, as well as adding some domains, particularly around assessment of documentation of goals. And then finally, we'll also be looking at the specialist provides visit summary to primary care provider. And there we're also thinking about how we can streamline the measures by basing this measure off of the same sample that's used for the care for older adults measure. And that's all testing that will be conducted in 2017. So our next steps is that we would like to recommend the follow-up after ED visit measure for HEDIS 2018. We will be bringing that also to our Committee on Performance Measurement for inclusion in public comment in February and March. And with that, I will pass it on to Sarah.
Thank you, Erin. First, I want to take the opportunity to thank Susan and Donna for the opportunity to allow me to come here and speak about IMPACT's work today. And I also want to echo Erin's sentiment about the importance of this work, and IMPACT is very honored to be a part of it. As Susan mentioned, IMPACT is currently supporting CMS in identifying and developing measures of care coordination using Medicare Advantage encounter data. As many of you are probably aware, Medicare Advantage encounter data is a particularly new data set. CMS began collecting data from managed care organizations and plans in a standardized way beginning in 2012. So because this is a particularly new data set, a critical component of Impact's work has been to test the feasibility of the encounter data for use in care coordination measure development and construction. So to do this, we confirmed both the completeness and accuracy of key data elements using external sources. These sources included analyses and reports by MedPAC, as well as HPMS data and data from the Encounter Data Workbench. As you can see from the slide, the results of our exploration confirmed sufficient completeness and validity among both beneficiary and plan level data elements. Plan level and beneficiary level data are both well populated and are consistent with external sources. And we found that encounter information such as HCPCS codes and ICD-9 codes allow for tracking over time, assessment of care patterns, and also are well defined for use in inequality measures. The next few slides will show summary statistics of key encounter data. To validate the encounter data, we used data from 2014, as this was the most complete data that we had at the time of our exploration. So the data that will follow and the data that I will discuss will be from the year 2014. In this year, you'll see from the slide that there were nearly 17.5 million beneficiaries enrolled in Medicare Advantage, of which about 94% had at least one encounter in the encounter data set. In the same year, there were just over 3,000 plans with enrollment, and of these, almost all plans, 99%, had filed at least one encounter. And again, these data were consistent with external sources. This next slide presents beneficiary summary statistics of the 2014 encounter data. As you can see, about 47% of beneficiaries are between the ages of 65 and 74, and this group constitutes about 41% of encounters in the encounter data set. As expected, the majority of beneficiaries or encounters are associated with beneficiaries 75 and older, and the majority of these beneficiaries are female and white. And again, these data were validated against external sources. This slide presents 2014 summary statistics of the most frequent and/or relevant chronic conditions as defined by CCW, or the Chronic Condition Warehouse. As expected, a large portion of Medicare Advantage beneficiaries have one or more chronic conditions. As you can see, approximately 33% of all beneficiaries have diabetes, according to the encounter data. And of all encounters in the year 2014, approximately 19% were associated with a beneficiary who had diabetes. Other common chronic conditions include hypertension, mental health, and heart failure. And you'll see the relevance of these particular chronic conditions as I discuss the measure set. So as we validated the encounter data, we simultaneously developed a framework to conceptualize and define care coordination measures for the MA context. This diagram presents the steps the impact team took to conceptualize and identify the care coordination measure set. Throughout this presentation, I'll go over each of these steps, and you'll see that many of the steps the impact team took correspond and align with the work that NCQA has done. Our focus was to identify care coordination measurement areas that are both recommended by national experts and also align with CMS quality strategy goals, as Susan and Donna described. As Donna mentioned, we used AHRQ's definition of care coordination as the basis for this work. As a result, process measures of practices that enable successful transition, including follow-up, served as a particularly high priority area for measure identification. In addition, because the MA encounter data gives us the opportunity to focus on services received or events, we also explored proxy or intermediate outcome measures that could be indicative of good or bad quality care coordination. Next slide, please. Thank you. We then conducted an extensive literature review to identify care coordination measure topics, components of successful coordination, and current mechanisms to measure coordination of care. Based on this review, the team identified care coordination domains, and these domains closely aligned with AHRQ's Measure Atlas, as Erin described. And these included care planning, effective care, and continuity of care, among other domains. Using the framework of the measurement domains, we then conducted an extensive environmental scan of existing nationally recognized care coordination measures across a variety of sources. We then evaluated each of these measures based on 3 primary components. The first is relevance to care coordination and CMS's priorities. The second is feasibility for implementation using the Medicare Advantage encounter data. And third, we evaluated the measures based on their measure type, giving more weight to outcome and process measures as compared to structural measures. Based on this assessment, the team identified a set of measures that are both highly relevant to care coordination and feasible to construct with the Medicare Advantage encounter data. Through this process, we also identified some significant gaps in care coordination and used this as part of our evaluation and in our work to identify the care coordination measure set. So based on this evaluation, CMS and the impact team selected 9 measures to pursue as part of this project. 4 of these measures are existing measures that Impact is currently adapting for use with MA encounter data, and 5 of these measures are de novo or new measures that we're developing from the ground up. Each of these measures closely align with the quality strategy goals and also focus on populations for whom care coordination is critical. This slide presents the 4 existing measures that the impact team is currently adapting. I should note that all of these measures are endorsed by NQF, or the National Quality Forum, and have been or are currently being used in performance measurement programs. Therefore, their significance to care coordination has been defined. The first measure on this slide evaluates the prevalence of potentially avoidable complications among 6 different chronic conditions. This measure is particularly important to care coordination because it directly assesses to what extent CMS's vision to promote effective coordination and communication is realized by providing appropriate interventions that prevent development of health conditions that require acute care. The 3 follow-up measures listed on this slide assess emergency department and hospitalization follow-up rates, both at 7-day and 30-day, among particularly vulnerable populations, and in this case, those with mental illness and also those with alcohol or other drug dependence. These measures address deficiencies related to discharge planning and transitions of care for beneficiaries at risk of losing contact with the healthcare system once they're discharged from costly hospitalization or ED visits. I should note that the 3 follow-up measures are each measures that have been developed by NCQA, and the impact team has worked very closely with NCQA and collaborated with them on the measure modifications. As I noted previously, although the 4 existing measures that the impact team is adapting cover important areas of chronic condition, or of care coordination, our work revealed important measurement gaps. To begin to address these gaps, CMS and the impact team identified 5 de novo measures to pursue. The first four measures listed on this slide address and assess ED and hospitalization for patients who have been discharged from ED and hospitalization, and look at follow-up rates among these beneficiaries. These are particularly costly and prevalent chronic conditions, and notably heart failure and diabetes in this case. The fifth measure on this slide assesses and evaluates unnecessary duplication of HbA1c testing, which is indicative of the lack of care coordination. As Susan mentioned, a critical component of our work to adapt and develop the measures have been consulting the literature, clinical guidelines, and working with subject matter experts, including our project's technical expert panel, to adapt and develop these measures. We have discussed all modifications with CMS and the measure stewards or owners of the four existing measures to ensure that these proposed changes are theoretically sound, meet the needs of the project, and also remain consistent with the intended purpose of the original measure. To establish the relevance and significance of the de novo measures, we've conducted extensive literature searches of relevant studies and articles and clinical guidelines, and again have consulted with subject matter experts. The process for both adapting and developing these measures is that we've worked with our technical expert panel and our SMEs to construct and define the numerator, denominator, and exclusion rules, and have collaborated with CMS on this process. The impact team recently completed initial testing of the measures and found that a large number of contracts and plan benefit packages have denominators large enough to provide meaningful data for measure construction. We also found large variation across plans, and that average scores indicate room for MA plans to improve across all of the 9 measures that I've discussed. To give you a little taste of our results, particularly related to the potentially avoidable complications measure, we found that the average rate of PACs among MA beneficiaries is 26%, and this range of, and we saw a range of scores, and these ranged widely from 0% to 100%. For the follow-up after ED for heart failure measure, for the 7-day follow-up measure, we found that the follow-up rate across all MA plans is 32%, and as expected, the average 30-day follow-up rate is similar, though higher, at 47%. Again, we saw a range of scores across MA plans. The lowest performing was 0%, and the highest 80%. I should note that these are preliminary findings and are very preliminary in nature. As I'll discuss on the next slide, the impact team will conduct rigorous testing and validation of these measures over the course of the next year. And so the measure specifications may change over time, therefore changing the scores that I've discussed today. So as a next step in the measure development process, we will conduct rigorous validation testing of each of these measures. This next phase of the project will be particularly important to prove reliability, validity, and feasibility indicators of each of these measures. In particular, we'll be examining whether these measures accurately and appropriately capture the care coordination performance of plans, whether the exclusions are appropriate for measurement purposes, and whether the scores are reliable and valid across plans. Now I'll pass it back over to Susan to close our talk.
Thank you. If you do have any questions regarding care coordination measures, you can contact the MA Policy Mailbox portal that is on the slide. And for further reading, you can refer to the Agency Healthcare Research and Quality Care Coordination Measures Atlas, which was updated June 2014. We also have our CMS Quality Strategy on our CMS website. as well as the blueprint for the CMS Measure Management System version 11.1, which was published August 2015. So, and if there are any questions?
Right, we are just about out of time right now. So if you do have questions, please hold those until the end of the day during the open Q&A session, and we will address them at that time. So I would like to thank our panel for the discussion on care coordination. All right, now it is time to go ahead and evaluate the session. If you would like to, go ahead and enter A into that cell phone or click on A at the Poll EV link. Our next presentation will highlight CMS's recent initiative to address Quimby billing rules and discuss MA plan obligations and recommended steps to protect dual-eligible enrollees from improper billing. From the Coordinated Healthcare Office, please help me welcome Kim Glon.
So good afternoon, I'm Kim Glon, and I work in the Federal Coordinated Healthcare Office. Our office is also known as the Medicare Medicaid Coordination Office, the Duals Office, or MMCO for short, but today I'm going to refer to us as MMCO. Many of you may be familiar with the work, with our work to implement demonstration programs that combine financing and delivery of services for Medicare and Medicaid. We have, to date, demonstrations that are live in 10 states, and over 350 participants are in these programs nationally. But today I wanted to talk to you about another focus of our office. We also work on trying to improve the experience of dual eligibles in the existing Medicare Advantage and Original Medicare programs. And today, my talk will focus on a really high priority CMS initiative that MMCO is helping to coordinate, and this is to help reduce the incidence of inappropriate billing of qualified Medicare beneficiaries. So on the first slide, you'll see an overview of what we'll cover today. I'm going to start with a brief background on Quimbys and their billing protections, and then I'll explain CMS's findings about inappropriate billing and the agency's concerted efforts to stem this practice. Next, I will relay Medicare Advantage requirements regarding Quimby billing that we have recently highlighted in instructions for plans and guidance and outreach that we've been doing. And also we'll tell you about new enhanced procedures that we're rolling out to support beneficiaries with billing problems. And then I will end with some additional resources that you can consult and open up things for questions. Okay. So just start with some brief background on Quimbys. Currently, there are about 10 million dual eligibles. That's people who are enrolled in Medicare and Medicaid. And Quimby is the largest eligibility group within the dual eligible population, with 65% of dual eligibles enrolled, and that's about 7 million enrollees nationally. So Quimby is a Medicaid benefit, and it pays Medicare cost sharing for persons with limited incomes. And you might have also heard of Quimby being called a Medicare savings programs. Just an aside, the Medicare savings programs are a group of Medicaid benefits that pay Medicare cost sharing for low-income Medicare beneficiaries. So Quimby is the most generous of the Medicare savings programs, and it helps pay all Medicare premiums and cost sharing for these limited income beneficiaries. You'll see in the slide also that Quimbys have annual incomes of less than $12,000 a year. So Quimbys actually cannot afford these Medicare costs without forgoing other life's necessities. So keep in mind that the bottom line is that Quimby is important because it helps to enable these low-income beneficiaries to afford their Medicare coverage. So in recognition of Quimby's limited resources and income and resources, federal law and regulations set forth billing protections for this population. Okay, actually, I jumped ahead. But on this slide, we're going to talk about some of those protections. So first and foremost, federal law prohibits Medicare providers from billing Quimby patients for Medicare cost sharing, and this requirement is unequivocal. It governs all Medicare providers, including Medicare Advantage providers and original Medicare providers, and keep in mind that all Medicare providers are subject to it, even those that do not accept Medicaid patients. In addition, it's important to note that CMS Medicare Advantage regulations also incorporate billing prohibitions for other groups of dual eligibles if the state holds these individuals harmless for Part A and B cost sharing. However, since most dual eligibles are Quimbys and the federal protections apply to Quimbys, our discussion of billing protections will focus on Quimbys today. Now, as I mentioned, the goal of Quimby is to assure Medicare access for low-income beneficiaries, and it does that by paying the Medicare premiums and cost sharing for this group of people. However, there's a little hitch with this, and federal law allows states to adopt policies that limit their payments to providers for this Medicare cost sharing. So states are permitted to pay providers who treat Quimbys at either the Medicaid rate or the Medicare rate, whichever is less. And these policies are known as lesser of policies. And they have the effect generally of reducing or negating the state payment of Medicare cost sharing to these low-income Medicare beneficiaries. So as an aside, I just want to note that states can apply these lesser of policies to all categories and all care settings, or they can use different rates depending on the service or the care setting. So for example, a state could apply a full payment rate to inpatient hospital care, which is more common, but apply a lesser of policy to outpatient physician services. As of January 2015, most states had adopted these lesser of policies, and mainly for outpatient physician services. As of that time, only the 11 states listed on the slide had full payment policies. The bottom line is that providers in these lesser states generally receive less for treating Quimby patients than they do for treating other Medicare patients. So this has raised worries that providers may limit the number of providers the number of Quimby patients they see, or that they may inadvertently charge these patients for the cost sharing. In view of these concerns, CMS commissioned a study to analyze and access and billing for Quimbys. And the study was released in 2015, last year, and it was based on beneficiary interviews across 3 states, specifically Michigan, Ohio, and South Dakota. And the link to the report is here. You can find it here. But I'll just review a few key findings in the next slide. Okay. First, unfortunately, the study did confirm that inappropriate billing is relatively commonplace and that it negatively affects beneficiaries and their family members. Also, the study revealed a great deal of confusion about the billing rules amongst providers and beneficiaries. And second, when study participants were billed, most said they paid the bills, either because they were worried, they weren't aware of the protections. Others said they were too ill to contest the matter. Still others said that they were worried about upsetting their provider and possibly undermining their future access to treatment. Another concerning finding was that many of these beneficiaries who didn't pay the bills said that they were referred to collection agencies, and this caused extreme distress for them. Many participants said that they had entered the appeals process after learning about their rules, so that was good. They were showed that they were exercising their rights, but they found that process pretty difficult to navigate. They required assistance from counselors, and then said that even when they won their appeal, they then found that it was very difficult for them to get timely reimbursement. Some at the time of the report, the study that was done, some were still awaiting reimbursement even after a positive finding in an appeal. Finally, participants generally voiced a lot of confusion about the billing processes, and they were really frustrated about the process and were worried about how the processes and bills might affect their access to care going forward. So as you can imagine, CMS takes these findings very seriously. In view of them, the agency has begun a concerted campaign to reduce the incidence of improper billing through 3 main strategies. And I'm going to review them on the slide just generally, just to let you know, give you a big picture of where the agency is going. So first, we're working to strengthen CMS-funded supports for beneficiaries, for example, SHIPs, regional offices, 1-800-Medicare, and to also update our beneficiary-facing publications to make sure that they emphasize billing protections for Quimbys. Second, as you I'm sure aware, we've been updating our guidance for plans and providers to clarify the billing rules, and we've also been conducting outreach to provider associations and practice manager associations just to get the word out, just to make sure that providers are more aware and educated about the rules. And finally, we're exploring administrative reforms internally to help providers better identify who among their patients are Quimbys. And this, we're hoping, will really help with compliance. Just a note, we are aware as we proceed with this campaign that increased knowledge about the Quimby billing rules could affect access to care. So we're really monitoring that as we move forward. So now I'll turn to our efforts to clarify the rules and provide education about how the billing rules affect Medicare Advantage and Medicare Advantage plans and providers. So first, the 2017 call letter reminds plans about their obligations regarding Quimby billing. It reiterates that Quimby billing rules do apply to all Medicare Advantage providers, and it instructs plans to adopt measures to try to promote compliance. So, for example, plans are required to include Quimby billing rules in their provider contracts and to generally inform providers about the billing prohibitions. And second, the call letter and a subsequent policy update in our manuals, which is listed on the slide, the citation is there, clarify that the existing anti-discrimination requirements do have an effect on how providers treat patients who are Quimbys. So just to give you a little primer on this, or a little background. So the existing CMS manual guidance, as you know, has required plans to maintain procedures to ensure that network providers did not discriminate against enrollees based on certain factors, and one of those factors was source of payment. So in the call letter this year and in updated manual guidance, we clarify that these anti-discrimination provisions mean that Medicare Advantage providers cannot refuse to serve enrollees based on the fact that Medicaid pays their Medicare cost sharing, for example, through Quimby. In addition, the call letter recommends practices to promote compliance with the billing rules. And for example, we recommend that plans really affirmatively take steps to clarify known areas of confusion that we've found among providers. So for instance, we have heard or found that some Medicare Advantage providers have been unaware that they in fact are bound by the rules, thinking that maybe they only apply to original Medicare providers, or that they only apply to providers who also accept Medicaid patients, or that they only apply to dual eligible special needs plans, but not other Medicare Advantage plans. So these are some of the areas that we think plans can clarify for providers. Additionally, as part of your work to monitor provider compliance, we recommend that plans review your grievances and your complaint tracking module data to target outreach to providers and to remediate issues. And I'll talk to you a little bit about the complaint tracking module in a bit, but you may see more cases coming in through the complaint tracking module in the coming months. Okay. So in an effort to educate sponsors and solicit their feedback about the call letter instructions, and to learn more about like what are the Quimby processes in plans, and the CMS held a strategic conversation this summer with all the sponsors. And as a background, I think many of you are familiar with what strategic conversations are, but just in case, I wanted to tell you that there are these two-way conversations that CMS regional offices and has been holding with our Part C and D sponsors, and they're a really useful tool for us to try to educate sponsors about new programs or existing requirements and solicit your feedback and get more input from plans about their technical assistance needs. So this summer's conversation aimed to really reinforce the Quimby billing rules and actually to help us learn what plans are actually doing around these Quimby billing issues, and also to identify promising practices to promote compliance and what are the plan's technical assistance needs. So the conversations wrapped up late last month, and we're still reviewing the results, the responses we received, but we really do appreciate the thoughtfulness of the replies. We've been looking at them, and we hope once we analyze the results, we hope to share more with you about what we've learned, and we would like to give more instructions that might be helpful to plans. So preliminarily, I'd like just to share a few strategies that plans have found effective that were mentioned. One is some plans recommend identifying Quimby status for their providers really early on in the process. so that provider offices know at the point of service delivery not to charge a patient. So for example, some plans mention that they might allow provider offices to access their online eligibility systems, and they think that this might have the effect of kind of letting the front office staff know that this patient is a Quimby and not to charge the patient, so that might head off an issue from ever happening. So another promising practice that plans mentioned was that on the back end, some plans are sort of looking at their EOPs or remittance device, and they're analyzing them to make sure that they're really clear for these patients that charges don't apply. So again, we're hoping to release more information to you about what some promising strategies might be, but stay tuned for those. And we also note that plans did request some forms of technical assistance, and we're reviewing those. So we hear you, and we're looking for ways that we can provide assistance in that regard. But in a few moments, I will poll the audience too, just about some of these forms of technical assistance too. But before I do that, I just wanted to make you aware of some imminent changes to Medicare and You and to 1-800-Medicare that are intended to increase support for these Quimby beneficiaries. So first, Medicare and You 2017 includes new language regarding Quimby billing protections, and it lists 1-800-Medicare as a resource for beneficiaries who have tried to resolve issues with their providers or plans but been unable to do so. And as you know, Medicare and You is getting mailed to beneficiaries this month. So in conjunction with this, 1-800-Medicare has been ramping up its supports for beneficiaries. It's rolling out new protocols as we speak to enhance its capacity to help Quimby billing, to help address Quimby billing issues. And so as of October of this year, 1-800-Medicare customer service representatives will be able to identify a caller's Quimby status and then give instructions about their billing protections. Additionally, if enrollees continue to have problems even after trying to resolve them, they can call 1-800-BACK, and the customer service representatives will then enter the cases into the complaint tracking module for plans to resolve. So that's where you may see more activity in the complaint tracking module from these cases. So here's a polling question I promised you. And again, so I just wanted to read it off for you, and so we can gauge sponsors' needs for technical assistance. So which of the following CMS measures could help build your capacity to promote compliance with the Quimby billing rules? A, technical information on how to identify Quimby status. B, best practices regarding provider education and oversight. C, additional manual guidance to clarify billing rules. Or D, revisions to member ID cards and model marketing materials to emphasize Quimby billing protections. And remember, you can select as many of these choices as you think apply. Okay, I'll just give you another moment to submit your responses. Okay. Okay. Okay, so it looks like we have an evolving poll, but it looks like about a third of participants in the poll think that more technical assistance on how to identify Quimby status might be valuable, some information about best practices, and also revisions to model Marketing materials and ID cards may also be in order. So less seem to be asking for additional manual guidance to clarify the rules. So thank you for participating in this poll. Okay. Next slide. Okay. Okay. So the last two slides list additional resources on Quimby billing. And on this slide, we have included some resources that we released earlier this year. So you may want to check those out. This last slide lists some other resources as well. So again, if you're looking for more information, you can consult these resources as well. Okay. And thank you for participating in this session, and I want to open up for questions now. Okay. Thank you.
Hi, I'm Jill Ventura from Horizon Blue Cross and Blue Shield.
Hello.
Don't we think that these beneficiaries would be better served off in a D-SNP plan? So if an organization has a D-SNP plan offering, and these members are still residing in a Medicare Advantage plan, is there any conversation with the CMS, like how we do the auto-facilitated process to move members without drug into a drug plan? Is there any conversation about moving those members and some CMS process authorizing the movement and encouraging these members to go into a SNP plan?
Thank you for your comment. Actually, at this time, we do not differentiate the rules between the Medicare Advantage plans, in general, versus the D-SNPs, as we were saying. I think there is, D-SNPs have certain benefits that could lend themselves to dual eligibles themselves, but there is no, from our office at least, we're not steering beneficiaries to one plan versus the other at this time. So there are, just to let people know, there are a good number of dual eligibles in Medicare Advantage plans that are not D-SNPs, and the rules do have to be followed around billing for this population there.
Hi, my name is Gloria Yu from AmeriHealth Caritas. So we wanted clarification for non-participating providers, just how the rules apply.
Okay, that's a really good question that does come up. So basically, the bottom line is that dual eligible protections apply to Medicare covered services. And so in general, as you know, that tends to, depending on the Medicare Advantage plan, but oftentimes the Medicare Advantage contract providers would be subject to the services if the services are covered. But there are some exceptions, like for even when non-contract providers treat patients, like, for example, emergency services, urgent care services, or when a provider, network provider, has authorized out-of-network care. So in those situations, even in the non-Quimby status, plans are required to provide coverage for those services. So the bottom line is a service covered by the plan? And if it is covered, then it is subject to the Quimby protections. But if it's not covered, the Quimby protections don't apply. So, for example, if it's an unauthorized service, there's no sort of legitimate reason why a non-participating provider's service should be covered, then the plan then we would say that the Quimby protections don't apply because it's not covered at all under Medicare Advantage.
All right, we are out of time at this point, so if you have additional questions, please hang on to them until the end of the day. And I would like to thank Kim for providing an understanding of CMS's initiatives and recent manual revisions. Thank you. Okay, if you would like to evaluate the session, please take out your phone and text A to get the link for the survey, or go to the Poll EV link and click on A and then go to the survey. Also, I wanted to announce again that we still have that black portfolio that was found. So if you are missing your black portfolio, go to the table that's outside the door and they can help you with that. It is also time for a quick break, so I would ask that everybody return at 3:05 for our next session. And remember, if you have questions for our virtual audience, please send them in via the SurveyMonkey link so we can address them during our open Q&A session. So we will see you back here at 3:05. Thank you. Welcome back to all of our in-house guests and also to those who are in our viewing audience. We thank you for being on time. Just a couple reminders before we move on to our next presentation. And that is, remember to send in your questions for any speakers via the link that was provided on the CT webpage, that we will have that open Q&A session at the end for any questions you still have. And also, if you would like to provide feedback for today's event, you will be mailed a link to an event survey that will be emailed to you at the end of this event. Please consider taking a few minutes to complete that. CMS does use the information to help improve as we move forward and plan additional conferences. Our next speaker will educate us on the recent enactment of the Comprehensive Addiction and Rehabilitation Act, and will also discuss how this law impacts Medicare Part D. I am happy to introduce to you Mr. Chad Buskirk.
Good afternoon. Now I'm going to talk about the Comprehensive Addiction and Recovery Act, as it's actually called, and how it relates to Medicare Part D. This is just a brief overview of some of what people commonly refer to as the lock-in provisions. The Comprehensive Addiction and Recovery Act, known as Cara, became law on July 22nd of this year to be effective on or after January 1st of 2019. It requires rulemaking and stakeholder participation. I know you're all interested in this aspect of the law, so I've saved the best for last. The Medicare Part D provision allows Part D sponsors to establish a drug management program which may limit an at-risk beneficiary's access to a controlled substance that CMS designates frequently abused or diverted. Their access would be limited to certain prescribers and pharmacies. Who is considered at risk? A beneficiary is deemed to be at risk if he or she has been identified through the use of clinical guidelines that indicate misuse or abuse of frequently abused drugs. The beneficiary is also identified as at risk from their most recent Part D plan, and their identification in that plan was not terminated. Finally, they have to be not exempted, which would apply to beneficiaries who receive hospice care, reside in long-term care facilities, or are considered to be exempt by CMS. A few of the requirements that Part D sponsors have is that they are not authorized to limit access until they have provided a beneficiary with an initial notice and verified with the beneficiary's providers that the beneficiary is indeed at risk. And the law provides some detail about the notices. The initial notice, which I had already mentioned, explains how the sponsor has identified the beneficiary as being possibly at risk. It also contains supplemental information and resources about prescription drug abuse, as well as organizations that can assist the beneficiary through the established drug management program. The notice also requests that the beneficiary submit their preferences for the pharmacies and providers that they would be limited to. The notice also has information about appeal rights and how to contact the Part D sponsor. On the previous slide, I had mentioned verification with the beneficiary's providers that they are at risk. After this verification, the law provides for a second notice. The sponsor sends the second notice no less than 30 days after the initial notice. This notice is very similar to, but not the same as the first. It explains that the Part D sponsor has identified the beneficiary as being definitively at risk. The beneficiary is now subject to the requirements of the sponsor's drug management program. It contains the prescribers and pharmacies that were selected for the beneficiary that were selected for the beneficiary. If the beneficiary hasn't submitted their preferences still, they are requested to do so again. And it again includes information about appeal rights and ways to contact the Part D sponsor. Another notice referenced in the law is a point of sale notice. A point of sale notice is provided to an at-risk beneficiary when he or she attempts to purchase a frequently abused drug at a non-selected pharmacy. This notice also explains why the beneficiary cannot obtain the drug under their plan. As to selection of prescribers and pharmacies that an at-risk beneficiary is indeed limited to, the Part D sponsor selects them from the beneficiary's list of preferences. The sponsor has to notify the prescriber and pharmacy before they have been selected. The sponsor also may change the beneficiary choice of either prescriber or pharmacy if they determine that the specified providers contribute to drug abuse or diversion. The sponsor has to provide 30 days notice of these changes and an explanation as to why they were necessary. In making the selection for the prescriber and pharmacy, a sponsor must ensure reasonable access by taking into account geographic location, beneficiary preference, cost sharing, impact, time to travel, emergencies, and natural disasters. As I mentioned before, there will be a stakeholder meeting that will be held no later than January 1st of 2017. Notices are sent to these various stakeholders in various formats in various ways. The topics to be discussed are the law's impact on cost sharing and accessibility, which beneficiaries should be considered exempt, or the responsibilities of the Part D sponsors involved in the program. And also involved in these stakeholder meetings are Medicare beneficiaries, obviously, beneficiary advocacy groups, physicians, pharmacists, and other clinicians who prescribe, such as dentists, retail pharmacies, plan sponsors, entities delegated by plan sponsors such as pharmacy benefit managers, and drug manufacturers. Any questions?
All right, if you have a question, please move to the center aisle to the microphone. And tell us your name and who you are with, please.
Yes, Scott Levine, Affinity Health Plan. I actually just sent this to the SurveyMonkey website, but I might as well ask it now. Mm-hmm. Is it the intent of Cara, or can Cara potentially be used to limit overprescribing of a drug in cases where suspected resale is believed?
Well, that's a good question. The best answer I can give at this time is we're working on scheduling the stakeholder meeting and still hammering out details into terms of what exactly.
Because obviously the bottom line there is that if that person is using the drug for personal use, it's, clearly they're at risk. But, if it's pretty evident that that's probably not occurring, then again, it all has to do with what's the intent of the law.
Yeah, I can't really.
I know, I understand. Thank you.
Hello, I'm Steve Ludwig, and I'm a CMS employee, and I was just wondering how long the status of a beneficiary is supposed to last once they are considered to be at risk. Under what conditions would they no longer be considered to be at risk?
That's a really good question. As I mentioned before, the stakeholder meeting that we have organized will help us with the input from other providers about exactly the details of how we're going to roll out the law as defined by our rulemaking.
Thank you.
Okay, any other questions from our in-house audience? All right, and to our viewing audience, please feel free to send in any questions you have for the open Q&A session. And at this time, I would like to thank Chad for presenting with us today. Thank you. Okay, let me adjust the podium. He's very tall. All right. It is time now for those of you who would like to evaluate this session, which is session 7 with Chad. Go ahead and get your phones out. Go ahead and text A to get your survey link, or go to the Poll EV link and click on A to get your survey link. Nobody wants to evaluate that session, huh? Usually that bar is moving right away. All right, so we are delighted to have with us today our next speakers who will provide an understanding of anti-discrimination rules and regulations in regards to communication with people with disabilities and/or limited English proficiency. It is my pleasure to introduce to you Randy Brower, Jim Slade, and Arlena Williams-Smith.
Thank you.
Wow, applause before I speak.
I know. Hopefully you'll be applauding afterwards, too.
I don't think you will, but that's okay.
We're just kidding. All right, so you've seen the first slide. That's us. Well, at least Randy and I. This is Randy. I'm Jim.
I'm Arlena.
Let's see here.
Next.
Don't press it too many times. Oh, did we pass the question?
I don't know.
Go back one.
All right, next slide. There. Next slide. That's not our presentation.
Yeah.
Oh. Okay. Well. All right. So we put in this polling question. So this law has been around since 1973, Section 504, and we sort of want folks to start thinking about, can your organizations communicate with folks with disabilities? I'm surprised it's 100% yes. Do we know how many folks actually weighed in there?
You need the microphone.
Volume.
Can you hear me now?
There
Was I inaccessible? Okay, sorry about that. We've been running all day. This is the least stressful part of my day. Can you imagine that? Okay, first slide. It's pretty cool. 100% of folks say their organizations are accessible. I don't know how many people actually weighed in.
We're getting to know.
Oh,
No is creeping up.
Uh-oh. Give you a second. Give you another second. All right. Well, we're going to move forward, but that's pretty good. That's pretty good. So next slide. So the introduction, I'm not going to read this word for word, but essentially plans need to be able to communicate with disabled folks and offer them the same opportunity to participate in their plans as folks who aren't disabled. Discrimination really it's not like folks stumbling around saying, we're not going to talk with folks who are disabled. It can actually be a lot more subtle than that, like giving a disabled person less time to take an action, or as something as subtle as asking, you have someone on the phone and asking their son to read the document. It can be seen as discrimination as well. Because it could be exposing PII, PHI, whatever. So, when you start thinking about accessibility, it can really sort of go out in lots of different ways. So next slide. So section 1557 or section 504. So 1557, I don't know how much folks know about it, but it was in the ACA in 2010, and it sort of tried to pull together a bunch of types of laws relating to discrimination. Randy and I are going to talk about the disability part of it, and Arlena gets everything else. So we got the good part of the bargain. So next slide. So 1557 pulls together, Title VI of the Civil Rights Act of 1964, Title IX of the Education Amendments of 1972, the Age of Discrimination Act of 1975, and Section 504 of 1973. Now, what's the common denominator there? This is the era of the Grateful Dead and disco. So hopefully not too much of this is going to be breaking news to you guys. So 504 applies to disability. So, that's what Randy and I will be talking about, and, we get off easy on this presentation. Don't we, Arlena?
What about?
Okay, next slide. So the only thing that 1557 added that wasn't in those previous laws was discrimination based on sex, but that's not 504, so we're not going to cover it today. So I think I'm going to hand it over to Randy for the big question. He gets to start with the big question.
Woohoo, all
the
right.
one you all want to know the answer to.
Rock on. Okay. Well, the answer is yes. So,
That's one of two one-word answers you'll ever get. The other one's later in the presentation.
So the question's at the top. So what I was expecting to see was the question on a slide, followed by the answer on a slide. But that came as a surprise to me. But surprise, surprise, the answer is yes. Medicare health plans, prescription drug plans, et cetera, must comply with Section 504. You are, in fact, covered entities. And for a variety of reasons under Section 1557, that question is absolutely certain at this point. There is no question about it. Moving on. All right, communication accessibility. So the thing that's, I think, the most important for everyone to remember, as Jim was introducing, is that we have to be able to communicate with people who have disabilities in the same way we communicate with others. Now, in the same way doesn't mean necessarily by the same mechanism, but means that we provide the same information in the same time frames to people who need them in alternate formats. So, for example, a person who's visually impaired might require Braille because that's how they read. They might require audio CDs. They might require a data CD so they can use their on-screen reader like JAWS or other such thing. But the other thing to keep in mind here that we want to really stress today is that communication is a two-way street. So a lot of us, when we think about 504 and accessibility for people, particularly the visually impaired, we think about providing documents in Braille or large print. But you have to also think about the incoming information into your organization. This means accessibility in your electronic environment, your online enrollment centers, your online health accounts through your organizations. Those must be accessible as well. So it is a two-way conversation. Moving on. I'm going to ask you for the next slide. This isn't doing its thing. Thank you. So what do you have to do? You have to entertain requests from individuals who ask for auxiliary aids and services in order to communicate effectively with you. Some of those include large print, Braille, text-type telephones, video remote interpreting services, qualified sign language, qualified interpreters, and so on and so on. Qualified readers is another that's fairly common. Again, the thing that's important to remember here is that when an individual says to you, I need you to communicate with me in another way, you have to entertain that request. And so we're going to dig a little bit deeper into that right now. Next slide, please. Okay, again, it's a two-way street. So things that are online for you could include your online appointment systems, electronic billing, information kiosks, your internets, and websites, and other such things that individuals might be accessing. So generally speaking, a lot of us think of Section 508 from the same law that brought you Section 504 as a way to achieve compliance with accessibility. And it is true that Section 508 is one of the industry standards that you can follow. But what I'd like to encourage you to do is to try and think about developing accessible inbound communications that are end user friendly, not just simply compliant. So for example, a 508 compliant mechanism might be to create a PDF document that is fillable. That does meet the standard of 508 compliance in most cases. However, a lot of PDF fillable forms don't function on Apple products or on tablets or other mobile devices. So while you may have met the standard of 508, you haven't necessarily provided a fully accessible mechanism for your membership. So I'd like to encourage you to not just think about we will be 508 compliant and therefore we will be square with the law. While that may be true, I'd like this to be a more fulsome conversation about ensuring accessibility for folks who have disabilities, particularly in the Medicare healthcare space, when you consider that one of the reasons an individual might be entitled to Medicare is disability. Next slide, please. Okay, so we thought it would be helpful to share with you a little bit about what we do at CMS. So at CMS, we promote the availability of accessible formats to individuals by including notices and other information in large publications like Medicare and You, and we'll be building in all of the other notice requirements brought to you by Section 1557. CMS offers a standard menu of non-standard or alternate format requests. We offer Braille, 18-point font large print, audio CDs, data CDs, and qualified reader service. Now, the very important thing to remember here is that this is the list of things we offer that are easily provided, and we hope and have so far experienced that generally this satisfies most people's needs. But we always entertain the individual's request first. So if the individual has requested something that's not on this list, so for example, a font size larger than 18 point, we do not summarily reject that request. We must entertain it, we must evaluate it, and work with the individual to try and arrive at a place where we are providing accessible communication that meets their needs. Next slide, please. So one question we hear a lot as we're helping people move down this path a little bit farther is, well, can we ever say no? Well, yes, you can say no. But the standard by which you have to measure the ability to turn somebody down when they've asked you for an accessible format is that you are not required by the law to take an action that you can demonstrate would be a fundamental alteration to your program or the services therein, or an undue financial or administrative burden. I cannot stress enough how high of a standard this is. Just because something costs a couple dollars is not an undue burden. But let's talk about money for a minute there. So some of the things we've heard is that this will be ridiculously expensive. I'd like to help you relax a little bit about that because CMS is a very big place, and just in the Medicare program alone, we've got over 58 million people enrolled. And I can assure you that we are not spending millions and millions and millions of dollars to ensure compliance and to communicate with people. So you should not expect that this is going to be a ridiculous burden in any way, shape, or form. But at the same time, you do have to be mindful that this has got to be a part of your business plan and ensure that you've set up your processes, your call centers, training for your staff, and other things that'll ensure that individuals who ask for information in formats other than your standard print will be provided the opportunity to receive those things and be able to communicate with your organization. Next slide.
And the only thing I might add to that is, even if you were to turn someone down, you still want to work with them to find a way to effectively communicate with them.
That's a great point, Jim. And I think from my position, I would be surprised if anyone ever arrived at the answer no. I just don't think you're ever going to get there. But if you ever did, if you ever did, that doesn't absolve you of the need to work with the person to find an accessible format. Okay, so recapping real quick, and then we're going to go through a couple of the questions we've received from folks over the last couple of months. So the highlights: you cannot discriminate on the basis of a disability. And as Jim was saying earlier, discrimination can be very subtle. It's probably not intentional. It's very unlikely that anyone out there is thinking, we just simply don't want to talk to those people who have a visual impairment. But rather making sure you think about how your programs are designed, your websites, your availability, your call center's responsiveness to people's requests for things in alternate formats. Not being responsive to something can be viewed as discrimination. Take appropriate steps to ensure that effective communications are in place, both incoming and outgoing. Notice requirements. You have to notify people. This has been a part of 504 since the mid-1970s, but it's also way more prevalent and obvious under 1557, which Arlena will talk about in a couple minutes. IT accessibility and electronics, again, can't stress enough that this is not just about producing documents in Braille or large print. This is about communications, and that is a two-way street. And effective mechanisms to respond, including the grievance procedures that 1557 requires you have in place. Okay, let's move on to our questions. So if we can move to the next slide, please.
Right. So I'll read it in case anybody can't see it back there. But do Part C and D plans have to give notice that upon request, they will provide communications and publications in alternate formats?
All right. Next slide gives us the answer. Yes. You have to take steps to make sure individuals know that this is their right. So again, I won't read the slide to you there, but it's important that individuals are aware that they can come to you and ask for this. So that'll happen through the notice requirements that you'll be compliant with through 1557, the notice requirements that existed under Section 504. But I'd also like to encourage you to just generally promote accessibility, to make sure your call centers, your sales reps, your on-the-ground reps, all the folks who interact with the public are aware that this is important, that that's not just a legal compliance thing, it's just simply the right thing to do. Next slide.
So what is the expected turnaround time for providing information in an alternate format?
All right, next slide is the answer. And of course, it's a lovely, long answer, but the short version is there really isn't a specific time frame. We're not giving you you must respond in 48 hours or some other such thing. But the very important thing to remember here is that we want to ensure that you think about setting up mechanisms that are responsive in a timely manner so as to not impact the individual's ability to do the next step in a process or to unduly delay them. So think about, for example, appeals. In appeals, particularly in Part D, there are very tight turnaround times for things to happen. And if it takes you a couple of days to provide a notice to somebody in Braille, has that couple of days impacted that individual's ability to work within those timeframes? In situations like that, the timeframes need to be extended in order to ensure that individual has the same time that anyone else would have following notification. So for most things, you should just consider that, extending the timeframe when necessary. For things that are more complicated, certainly do come through your account manager and talk to us, and we will work with the Office of Civil Rights to make sure we get to the right place, as well as the component that owns those policies. But again, the short answer is there isn't a specific deadline. However, it really is important that you move quickly to ensure that individuals receive information in a timely manner, particularly when the receipt of the information impacts their ability to move to the next step. Next slide, please.
Will Part C and D plans have to have the same menu of standard alternate formats available as CMS has available?
And the next slide is the answer, and the answer is no. We shared that with you because we think that it's kind of a best practice. Ooh, I could not say that. But, again, it's not something you must do. But I think you'll find over time as you begin to do this or make this more fully embedded in your operations that generally speaking, folks will be looking for similar things. Large print is by far the most often requested thing that we've experienced. So having things available on a menu makes things a little easier for your call center, for example. That way you don't have to adjudicate each individual request if it's easily fulfilled through a setup sort of like this. However, having said that, you're not required to have a standard menu of things, nor are you required to copy our standard menu of things. We shared it with you because I think it's useful. We hope that you'll think about a mechanism like that to streamline your operations, but it's not required. Next slide.
Will enrollees have to make their request for an alternate format each time the enrollee wants to receive a communication in an alternate format?
And the next slide, please. And this is an important one, so I want to pause here and talk about this for a minute. The answer is no, and this is pretty important. One of the things that individuals have complained to CMS about, particularly, is that every time they need something, they have to call again and again and again. And that really isn't what the spirit and the requirements are here. So when an individual reaches out to your organization and requests to receive things in an alternate language, looking at Arlena, and or an alternate format for the information we're talking about, we do expect that you have the ability or will build the ability to capture that request and produce all of the materials that you push out to individuals following the receipt of that request in the format that the individual has asked for. Next slide. Oh, wait a minute. I'm going to go back just 1 second. Can you go back? I missed the potential enrollee thing, and I do want to mention that. We got a specific question about this. So a person who gives your call center a call, they're not a member of your health plan, they're just looking for sales material, and they tell you they'd like to receive it in large print, please. Yes, you do need to provide that information in large print because they've asked for it. But do you need to retain that information such that the next time they ask you for another piece of marketing material, you can fulfill it in large print? And the answer is no. We think that that would be a bit more of a burden than is necessary. Once the person becomes your enrollee, however, we do expect that you're able to know what their preference is and communicate with them that way. Okay, next slide, please.
So what evidence is needed to prove a disability in order to receive communications in an alternate format? And here comes the other one-word answer.
Moving on to the next slide. None. So just to say that again, you cannot ask people to prove that they have a disability. There is no burden of proof on the individual. If they ask for information in a format that for an accessible purpose, you need to provide it within reason. Next slide, please.
Will Part C and D plans have to convert all documents into various alternate formats in anticipation of a request?
And the next slide. And no, you do not. So this was a very common question we received after we spoke briefly in June with you all. Do I have to have, just warehouses full of things printed in Braille or large print? And the answer is no, you do not. But again, you need to keep in mind that you need to be able to be responsive to individuals. So if a certain document having that on hand might be helpful, that's great. These are business decisions that you will make, but I didn't want you to think that you had a requirement to fill up a warehouse full of pre-printed or pre-created documents. Let me give you a little bit about what we do. So at CMS, generally speaking, we print on demand. When an individual has told us they have an alternate format need, every time we create something for that individual, we try to capture it and get it printed in or created in that particular format. There are some things, though, that we keep a small supply of. For example, the Medicare New Handbook. That's a large document that you're all very familiar with. So we do keep a small supply on hand of large print and a couple of Braille documents so that when we get a request throughout the year, we can fulfill it easily. That's an example of a place where we do keep a few things in stock. But it's not your requirement. Again, think about your needs as you get to know your population and their needs, what makes the most sense for you. There's only 2 more of these left. Next slide.
Are plans required to provide both a standard and alternate format?
And the answer is another really long answer. The short answer is, well, you're not required to, but you need to think about this. So again, consider, for example, the appeals process. So in our world here at CMS, we provide individuals with their Medicare Summary Notice, or MSN. And from that, an individual might be moved to enter the appeals process. Well, if we've provided that Medicare summary notice on a data CD or in a Braille format, it won't be readily usable for the individual to submit as part of their appeal request. So we do provide both the regular standard paper and the alternate format. And we think that that is a very good business practice, and we'd like you all to consider that strongly. Things that require the individual to take the next step, if you've provided it in an alternate format, may not be easily usable by that person for that necessary next step. Last one.
All right. What should plans do if it has questions about the provision of communications and publications in alternate formats to disabled individuals under Section 504?
All right. And so the answer is we'd like you to work with your account managers, please. So the 504 accessibility team at CMS is pretty small at the moment, but we're building up and we're doing our best. But to ensure that we are being consistent and that the whole agency is marching in this direction, we really want to encourage you to contact your regional office account managers if you have ongoing questions about 504 compliance. If they don't have the answer from us already, they'll reach out to our team and we'll work together to make sure we get an answer that we then share across the nation with all the account managers so you all get the same answer every time you ask the question, no matter where you ask it. So that's the point. We really want to encourage you to use that mechanism. And again, this is specific to 504. And you saw in an email blast from HPMS last week or so that for 1557, generally speaking, the language issues and notice requirements that CM is directing you to the Office of Civil Rights. For 504, we want you to come through your account manager to us and not directly to the Office for Civil Rights. And the very last slide here is just restating that for you. Your account manager comes through to us. We are doing our best to put together a list of FAQs that will include these and a bunch more, and we will provide that out through HPMS in an effort to keep providing as much guidance as we can. I think the big takeaway for this particular part of the conversation is to say that ensuring that we are accessible is very important. Making sure that individuals are not disadvantaged intentionally or unintentionally is important. This shouldn't be a tremendous burden. There might be a little lift at the beginning if you haven't been thinking about this globally already, but I think that generally speaking, you'll be glad that you are able to communicate with everybody who is a participant in the Medicare program. And with that, I'm going to move to Arlena.
Thanks, Randy. Again, my name is Arlena Williams-Smith. I work in the Division of Surveillance, Compliance, and Marketing. Before I get deep into the presentation, I have a poll question for you guys. Next slide, please. Next slide. Do you have concerns with the implementation of Section 1557 of the Affordable Care Act as it relates to marketing? Yes. No. Are you kidding me? Yes. I was expecting a lot of no's.
Seriously? There's not a single no? Thank you. Thank you very much.
Well,
hopefully... Wait, you changed your answer. No fair.
Well, hopefully this presentation will address at least some of the concerns you had. Next slide, please. What is Section 1557? As Randy mentioned during his presentation, Section 1557 is a non-discrimination provision of the Affordable Care Act. The law prohibits discrimination on the basis of race, color, national origin, sex, age, and disability. The rule applies to every health program or activity that receives HHS funding, every health program or activity administered by HHS, and every health program, every health program or activity administered by the entity created by Title I of the ACA. Examples of covered entities includes hospitals, health clinics, health insurance programs, state Medicaid agencies, community health centers, physician practices, home health care agencies, and health insurance marketplaces. Next slide, please. What is the impact on communication materials? Plans and Part D sponsors are required to include the non-discrimination notice or tagline on significant beneficiary information communications. The requirement applies to plans and Part D sponsors and their downstream entities. CMS, in conjunction with OCR, developed guidance on August 8th and also August 9th to help plans comply with the non-discrimination communication requirements. In accordance with the regulation, plans and Part D sponsors are permitted to exhaust their existing stock of publications with the current notice before using the new notice. Plan and Part D sponsors are not required to submit previously submitted material when including the non-discrimination notice or tagline. OCR is going to release a frequently asked questions document, which should help answer some of the outstanding questions that we've been receiving. So we're waiting on clarification as well. Next slide, please. Section 1557 regulation stipulates that plans must post a notice of non-discrimination in at least the top 15 non-English language languages spoken by state or states, the top 15 non-English languages by state or states in which they operate. Plans have the option to use the language in Appendix A of the final rule, or plans may create their own non-discrimination notice. The notice must include a notice that the plan or party sponsor does not discriminate on the basis of race, color, national origin, sex, age, or disability, a statement that the plan party sponsor provides auxiliary services and aids free of service in a timely manner to individuals with disabilities, language assistance services free of charge in a timely manner to individuals with limited English proficiency. Next slide, please. Information on how to access aids and services referenced in the previous slide. The notice must include contact information for the compliance coordinator, individual, or department coordinating compliance with Section 1557. A notice that states there is a grievance procedure and information on how to file a grievance, and lastly, information on how to file a complaint with OCR. Next slide, please. The non-discrimination statement states that plan and party sponsors comply with applicable federal civil rights laws and does not discriminate on the basis of race, color, national origin, age, disability, or sex. It is intended for small size materials. Next slide, please. Language assistance taglines. Plan and party sponsors are required to post taglines in at least the top 15 languages spoken by individuals with limited English proficiency by the state or states in which they operate. In the event the service area includes more than one state, plans must ensure that all the languages applicable for the state are included in the document. In some cases, this will exceed 15 languages. The top 15 languages by state will be found in the future on the Office for Civil Rights website. We continue to urge plans and party sponsors to review the information currently available on OCR's website with regard to what materials require a notice of non-discrimination or statement of non-discrimination, as well as the appropriate number and mix of taglines. Lastly, the Section 1557 tagline language has replaced the non-discrimination disclaimer in Section 50.4 of the Medicare Marketing Guidelines. Next slide, please. Poll question. Help, I've already submitted my 27 MLI. What do I do? A, resubmit. B, withdraw, or C, nothing. Are you kidding me?
You can't influence them.
Are you kidding me? I'm sorry. The answer is plans and party sponsors are not required to resubmit previously submitted materials when including the non-discrimination tagline or notice. Next slide, please. Another poll question. I already have existing stock. Can I use it? A, yes. B, no. C, not sure. Okay, I'm going to put you out of your misery. In accordance with the regulation, planned party sponsors are permitted to exhaust their existing stock of publications with the current notice before using the new notice. I want to touch a little bit on the grievance process, the grievance procedure, sorry. Organizations with 15 or more employees are required to have a civil rights grievance procedure and an employee designated to coordinate those compliance efforts. Organizations are required to post information telling customers with disabilities and customers with limited English proficiency about their right to receive communication assistance and the availability of free language assistance services. Plans and party sponsors are required to post a non-discrimination statement in a conspicuous location that's visible to beneficiaries, enrollees, applicants, and members of the public. And also, in a conspicuous location on the website, accessible from the home page. Next slide, please. Just to recap, I would like to just go over what we've discussed. Plans and party sponsors may exhaust their existing publications. They may use the sample language provided by OCR in the appendix section of the final rule. You can incorporate a grievance process in a existing process. You may include the name of a specific department in the notice in lieu of a specific compliance coordinator, as long as the staff are trained on how to address Section 1557 issues. Next slide, please. Also, plans and party sponsors are not required to resubmit previously approved 2017 marketing materials when adding the applicable non-discrimination notice or tagline. They are not required to submit the information to the AM for review that they've created. And also, they are not required to require the enrollee to exhaust the internal grievance process prior to filing a complaint with OCR.
Arlena, if I could just jump in there.
Sure.
I would clarify just a little on that to say that you may not. It's not that you're not required to allow enrollees to exhaust. You may not require enrollees to exhaust your internal process. An individual always has the right to file a grievance or a complaint directly with OCR.
Thank you. Next slide, please. For assistance with Section 1557, please direct your questions to the 1557 mailbox. And if you have questions related to marketing in Section 1557, those questions can be directed to the marketing mailbox at CMS. And the information is on the screen for you. Next slide, please. Thank you.
All right.
Okay, we do have a few minutes for questions, so if our in-house audience has a question, please step to the center microphone. Tell us who you are and where you're from.
Hi, I'm Michelle Johansson, Performer X. Thank you, Randy, for your presentation and for clarifying CMS's expectation that once the beneficiary says that they need it in an alternate format, that they should always receive the document in an alternate format. So now I have a mechanical question for you.
All right, bring it.
So A, would it be possible to have that committed to in writing in terms of the marketing guidelines? And I don't believe that it's in there in that very specific way. And then B, so we're a pharmacy benefit manager, so we're first tier. And we, for example, process coverage determinations and redeterminations. And we rely on the eligibility file information that we receive from plan sponsors. Right now, I'm going to go home and figure out whether or not we even have a spot on the eligibility file for all the unique types of
Sure.
alternate formats. And if we do, okay. If we don't, is there going to be time from an industry perspective to develop that? And then if we do have the ability to receive it, I guess, what's the expectation if, say, for example, the plan now, they get a phone call and it's at their member service department. The member service department says they receive the request that the beneficiary wants it in Braille. What have you seen as a best practice to get that call connected to an action that's going to result in a first-tier entity being able to always produce a document in Braille?
Wow, that's a lot of questions. That's great. So first one first, yes, we will provide this in writing, most likely via an FAQ type document. The level of specificity for accessibility for folks with disabilities doesn't really merit its own manual chapter. Over time, we'd like to work with our components in CM to get some of those things woven into all the manual chapters that you're familiar with, 2 and 3, and the marketing guidelines and so on. But rather than try and cross that bridge first, we'll put out a document from the office that Jim and I run to make sure everybody's got what they need and can move forward. And I understand fully why you're asking that question. As far as best practices to get something from point A to point B, and what do we do if we don't have that field? Well, no one expects that you're going to go home and flip a switch and turn on something that's not there. So I'd like to assure you that, yes, of course, there's time, quote unquote, I'm using air quotes for that. Now, it's a tricky answer in the sense that compliance for this sort of activity has been mandated for the last 43 years. So I can't really say that, oh, sure, next year is fine. I need to say that, well, no, you need to be able to do this now, but we're also reasonable. So we're edging now into the compliance conversation. And, Jim and I will be managing, working with you all on helping to get to the best possible place. We understand that, again, there's no magic wand if this isn't already there. On the other hand, we want to encourage folks to try and move as nimbly as they can. From my perspective, this is a business decision for you as a downstream entity or a first tier, as a pharmacy benefit manager. It would seem to me that one reasonable approach might be to work with the organizations that you support to have their eligibility file pass that information to you, as it's more likely than not that they would be collecting it through their customer service interactions. But that's not the only model. It's just one that seems to sort of make sense on its face.
Thank you.
Does that help?
Very helpful. Thank
All
you.
right.
Okay, we do have time for one additional question, if we have one out there.
Hi, this is Jen Souza from Medicare Compliance Solutions. We just have a question in terms of whether or not advertisements require a 1557 disclaimer, and also whether or not CMS is planning to do any oversight of 1557 requirements.
The answer to your second question is no, CMS is not.
With the exception of the 504 part of it.
Okay.
With regard to your first question, CMS is currently working with OCR to determine what's considered significant communications and publications. We're definitely, we put out some guidance that gave a little information about what we, CMS, thought that, or our interpretation of what OCR implemented. So right now we still are working with, like I said, OCR for clarification about the guidance as far as what is considered significant publications and communications. So I'm sorry, I don't have an answer for you.
Okay, thank you.
All that to say that, huh? I'm sorry.
That's okay.
But if it makes you feel any better, we have oversight entities too, and the Office of Civil Rights is CMS's oversight entity. So the department takes a close look at what we're doing, and that includes how we're working with you. And just to restate what Jim added to the answer there is that for Section 504, we will absolutely be working collaboratively with you all to ensure that we have effective mechanisms in place to make sure that we are all compliant with communicating with folks. The real takeaway there is that we want your help to develop mechanisms that make sense for oversight. We are not going to recreate anything, and of course we'll work within the structures that exist in the Center for Medicare already. But it's important to us that we are in the thread of oversight so that we can identify problems early and intervene and provide assistance to resolve them, as opposed to have them become issues at OCR, which is of course our oversight entity.
All right. Well, thank you. That is all the time we have right now for questions for this group. But if you do have additional questions, again, we'll bring them back up one more time. So I would like to thank Randy, Jim, and Arlena for sharing information on the anti-discrimination rules and regulations with us today. Thank you.
Awesome. Thank you.
Thanks, everyone.
All right, session 8, evaluation. Go ahead and pull out those phones or go to the Poll EV link and follow the link that is sent to you to answer those 4 questions. Our last session today is what we call an open Q&A session, and this means that we are going to bring up all of our speakers from today, and they will join us here on stage one session at a time. And each group will have a certain amount of time to answer any questions that were sent in from our audience today, or questions that you have in our viewing audience that have not been answered thus far. If we do not get to answer all of the questions, please send them in and we will respond to them and post them on the CTO website at a later date. Right, the first session that we had today was options for adjusting star ratings for audits and enforcement actions, and this was our listening session with Elizabeth Goldstein, Michelle Ketchum, Alice Lead Martin, and Sarah Gaio. So I would like to invite those 4 individuals to join me up on stage. Okay. Maybe not. Let's go to our second session then. The second session was Medicare Advantage application operational changes, and that was with Stacy Davis, Teresa Wachter, and Marty Ablin. If you can come on up and you can join me way over here. Here? This way? Nope. Oh, there's no room for you there.
Hello?
Okay, so no, come on over here. You're just going to stand next to me. Over here. Yeah, right over there. Am I close enough? You're close enough. Oh, don't hide. Come. Yep, Marty. Marty's trying to hide up here, so we're not going to let him hide. Okay, the first question that we received from our viewing audience is as follows. What if you have all providers in a county except one specialty area that is not within max travel and distance in a rural community? Why would this not be an exception for network adequacy?
So it depends. It might be. If what you're saying is that for one specialty within the rural county, there's not a sufficient supply of providers or facilities to meet that specialty, then absolutely you have that ability to submit that evidence through us through the exception request template, and that's something that we would consider.
Okay, next question we have. How many partial county requests were filed during the recent application process, and how many of those exceptions were granted?
So I don't think we have the data at this point to share regarding that question.
Okay, thank you.
Sorry about that.
Next question. It would be very helpful if CMS could allow a plan to test network adequacy through the year using the network adequacy module in HPMS for counties that are not in the plan's existing service area. This would allow plans to test network adequacy for new counties it is considering expanding into prior to the SAE timeframe.
So the good news is plans already have the ability to do this. Just as in the application module, in the network management module, there are no restrictions to your service area. You can test for any county you'd like that you're thinking about expanding to.
And I do have one more question here. Can CMS clarify whether providers must be both contracted and credentialed prior to being added to the HSD tables, or do they only need to be contracted?
So when you add a provider to the HSD table, we're assuming that's a provider that's in a position to furnish services to enrollees. So we would expect them to be credentialed and qualified otherwise to provide services.
Okay, and I see we do have a question from an in-house participant. Go ahead, please.
Hi, Lynn Wardinger, Geisinger Health Plan. My question is, if it is a rural area and the only practitioners who are practicing in a specialty are not board certified, but they are registered with Medicare, they're enrolled, is that reason enough to get an exception that we don't want to contract with them because they are not board certified in that specialty? Or is the fact that they're recognized to practice in that specialty by CMS enough?
Well, I'm presuming they've passed the credentialing requirements. And when you ask a question like that, what we generally look at are the providers qualified to provide services to, for example, beneficiaries in original Medicare. So the quality of care, the standards that are prevalent in original Medicare are the same levels that we would expect MA plans to provide. So I'm not sure about the answer to your question specifically, but if those same providers are able to provide services to enrollees in original Medicare and be paid, then that would not be a problem from our perspective.
Okay. Just was wondering if that would be reason for an exception if we did not contract with the only provider in an area that provided services in that specialty because they were not board certified. They basically said they were practicing in cardiology, but they have no particular credentials showing any specialty certification.
So, and I don't know if this will answer your question, but I would say that's a rationale you can certainly submit on the exception request template. What it sounds like you're saying is that you have evidence that a provider isn't appropriately credentialed to provide services. And from that perspective, that's something we would consider in terms of that the supply isn't there because they're not credentialed to offer that specialty.
Okay, thank you.
Okay, any additional questions for this session? I see we have one more. Go ahead, please. Could you please turn the back mic on? Thank you.
We good? Hi, Joe Richer from Anthem. Just a curious question, if there's any plans on the CMS end to streamline the network exception process. I understand there have been some challenges historically with exceptions that have been approved and then updated to be denied. I know it's a critical report that we rely on.
Could you please repeat that and try to talk more into the microphone?
Sure.
Sorry.
So the question is if CMS has any plans to streamline the network exception process. I understand there have been some challenges historically with those that have been approved and then subsequently denied.
So one of the things we highlighted, I think, during our presentation was we hold organizations and applicants accountable to current standards. And we made some policy clarifications this year. We required full network reviews. And I think to your point, it was a lot of work for plans that they might not have been prepared for. In terms of streamlining the exception process, again, we anticipate the same changes that were in play for this past application will be in play for contract year 2018. That exception request template is part of our Paperwork Reduction Act package that's going through the process right now. And I believe Teresa pointed out the 30-day comment period is going to start soon, so that's something to look out for if you wanted to comment on that.
Okay, great. Thank you.
I would just add that our goal is to make fewer exceptions necessary. In other words, that we have, and this is something we work on every year, that our data is better. We know that how many providers are in a geographic area, so the need to ask for exceptions is going to be reduced. It's a lot of work for us. It's a problem for you. And we want to bring that down and hopefully every year it's going to get better as we keep working on the process.
Great, thank you.
All right, that is all the time that we have for this group today, so please help me thank them for their participation. Okay, I'm going to step back and ask our first session, that would be Liz Goldstein, Michelle Ketchum, Alice Lee Martin, and Sarah Gaio, to please join me on stage. We have a few questions that were sent in from our viewing audience, and then if there's anybody in the in-house audience, please step forward. All right. Okay, the first question that was sent in Where do you find technical guide for 5-star ratings for Medicare Advantage and prescription drug plans?
So we're assuming you mean the technical notes for the star ratings. Those are available on the star ratings webpage on cms.gov, and that shortcut is go.cms.gov/Part C and D star ratings. You can also go to the cms.gov homepage and search for Part C and D performance data, and that'll take you to all of the past star ratings data, technical notes, and everything else star ratings related.
Okay, next, is there going to be any explanation at the beginning of the MPF about sanctions in general?
So this question sounds like they're asking on the Medicare Plan Finder, on the home page where you start your search, will there be information about sanctions in general? At this point, we will not be adding any information to that page about sanctions. The pop-up window that I had in my slide set, we had shown example text that explains what it means to be under sanction, that the plan had violated Medicare rules. So at this point, that'll be the information that we show in the Plan Finder.
Okay, next question that we received. If a plan performs exceptionally well, for example, a score of less than 1.0, would there be positive points to be added?
Interesting idea. I assume the commenter is referring to the calculation of the BAP measure. We would encourage the commenter to please submit more details on what they're suggesting, and we'll certainly take that into consideration.
Okay, thank you. And we do have here a process recommendation. So this is more of a comment than a question, but I will read it out loud. Aetna suggests that CMS consider implementing a process where any compliance actions that may have an impact to star ratings data integrity be vetted with the CMS STARS team prior to issuance, and that the compliance notification communicate whether a data integrity issue will be flagged. This will allow the MAO to understand the implication of the compliance notification to star ratings, and allow the MAO and CMS STARS teams to collaborate around the appropriate actions to ensure that data integrity is not compromised within the star ratings prospectively. We greatly appreciate the strides CMS has taken to do similar things around identifying beneficiary impact or past performance scorecard impact on notifications.
Yeah, just again, thank you for the comment. Another good idea. We're pleased that our discussion this morning is already stimulating a number of ideas, and we look forward to receiving more comments from you. So if you could, please submit your feedback by September 23rd to the Part C DQA at cms.hhs.gov website, and that way we can take any of those ideas into consideration ahead of our fall request for comments for the star ratings. Thank you again.
Okay, thank you so much. Okay, now moving on to the third session of the day, which was improving operations through audits. We have Michael DeBella, Jennifer O'Brien, Kate Metzler, Allison Green, and Jen Smith. If you could join me on stage, please. If we have anyone in-house with questions, please step to the microphone. Okay, the first question here says, my question is for the CMS team. This year, CMS sent out draft 2017 audit protocols for comments. Is there an estimated time frame of when the 2017 audit protocols will be final?
The protocols went out through the PRA process for a 60-day comment period. We are hoping to respond to the numerous comments we received on the protocols and would like to get them back out for a 30-day comment period. We're hoping for October, but that's not completely within our control. Once the 30-day comment period closes, then we would be able, and we get OMB sign-off, we would be able to issue them in final. But we don't anticipate true substantive changes on the comment period. I mean, most of the comments we received were not about changing elements or changing what we test, but instead were related to asking for clarifications of field descriptions and things that we wanted submitted in certain audit universes.
Okay, thank you. The next question, will CMS release new best practices?
CMS just released its 2015 annual audit and enforcement report on Tuesday of this week. In that annual report, we included a new section which includes all of our common conditions from the 2015 audits. We did not include any best practices, however, in that report.
All right, and I have one last question here. Can you direct us to the site that the CMS tracer example is located?
I will have to probably send that out. We can probably send that out afterwards. I don't have that right.
Yeah, if we don't have the answer right now, what we'll do is we will get the answers and we will post the answers to these questions on the CTEO website. Okay, that's all that I have for this group. Thank you. Okay, moving on to our next session, Online Provider Directory Review with Jeremy and Christine. We again received a number of questions for this group. So I will begin with those, and again, if there's someone in-house who has a question, please step forward. For both CMS monitoring of provider directories and requirements regarding monthly updates to directories, does it include printed PDF directories posted to the website, or does it only include the online search tool?
Yeah, when we looked at the websites, if there was an online search tool, we did our directory review using that online search tool. You have the option of just having the PDF on the website. If that was the only option, we use the PDF. The majority of cases, we use the online search tool because it was available.
Okay, thank you. Next question. If a plan delegates network contracting, for example, DME, HH, or SNF, is the first tier or delegate required to provide updates to plan within a particular period of time, and does the plan have 30 days from the date such updates are received to update its provider directory? Should plans require in its contracts with these types of delegates that the delegates provide updates to the provider directory to the plan at least every 30 days?
Our expectations are that the online directory is updated within 30 days of notification of a change. It doesn't matter whether that notification is directly to the MAO or an FDR. You are responsible for the actions of your first tier, downstream, and related entities. So notification to a third party, the clock would start then for updating within 30 calendar days of your online directory.
The next question we have, regarding providers not accepting new patients. Is it better to list a provider in a directory for members who are already on that provider's panel but isn't accepting new patients, or removing that provider from the directory altogether, risking the members not seeing the provider in the directory and assuming the provider is no longer participating?
I don't know that there's a steadfast rule for this, but I would think it would be better if the organization maintained all providers in the directory, whether they're accepting or not accepting new patients.
All right, next question. Is CMS willing to share the tools they use to conduct provider directory reviews, such as protocols, call scripts, etc., the same way protocols are shared for the program audit? This would help plans prepare for review.
We did say in the last call letter that we would put out a memo, and that's still in the works to put out, where we could cite some best practices as well as maybe talk a little bit more about the methodology. Although I would stress that what we reviewed is what's in the model directory. So it's really kind of an open book test from that perspective. There's not any sort of, nothing that's not transparent or available publicly already.
Okay, thank you. And I have one last question here. You talked about how group management might be thinking about group location versus provider location. However, many times, providers are at certain locations only some of the time and have varying office hours, varying even from day to day, and the group prefers that we list those providers at those varying locations. Does that satisfy the audit, or is that always going to be a strike against plans when it is the provider's request?
And I would answer that by saying our review took into account the fact that a provider may only be at a location once a month, once every couple of months. And so there were no findings as a result of that sort of situation. The fact that if you could call and make an appointment with that provider at that location, even if that was several months later, as long as that provider had a presence at that location and accepted appointments at that location, we were fine with that. So I think hopefully that answers the question.
Okay. All right, that brings an end to the questions that I have for Christine and Jeremy. So if you could help me thank them, please. Okay, our next session is care coordination measure development. Now, before I extend an invitation for this group to join me on stage, are there any questions from our in-house audience, because we did not receive questions online? Okay. All right, well, if there are no questions for this particular group, we will move to the next one, which was reducing inappropriate billing of qualified Medicare beneficiaries. So again, I am going to ask if there are any questions from our in-house guests before we bring them on stage. All right. Well, thank you, Kim, for participating with us today, and we'll move to the next session, which included Lisa Thorpe and Chad Buskirk, and that was overview of the Comprehensive Addiction and Recovery Act, or CARA. Again, I'd like to ask if there are any in-house questions for this session. Okay, and there does not appear to be. So we will move on to the last session that we had today, which is anti-discrimination rules and regulations. And I do have questions for this particular session, so I would like to invite you up on stage to join me. Okay, and again, if there is anyone in the in-house audience with a question, please move to the center aisle.
Party on.
Our first question today: is it permissible to provide an accessible format of a newsletter online, but also include the same information in a non-accessible format, such as flipbook?
So you obviously can provide it online in accessible format and in a non-accessible format. But, you know, if someone calls up and wants it in a certain, format, like large print or whatever, then you should provide it, because folks are supposed to have the same sort of information, opportunity to participate with your benefit as everyone else, folks who are non-disabled. So that's the answer.
Okay, we have an in-house question. Would you like to step to the mic, please? Oh.
It turned on again. There we go. Great. Joe Richer from Anthem again. Just a quick question. We had submitted a question to the marketing mailbox, I believe, inquiring whether we could add the required statements from 1557 to the multi-language insert, and I think the response that we received was pretty clear that that was a no at this point in time, and I just wanted to inquire if CMS will reconsider that, perhaps in the marketing off-season, if that's something we could do in the future to perhaps streamline all of those disclaimers for our members.
I'm sorry, you said which disclaimer you're referring to? 15, I'm sorry. 15.
Yeah, the 1557 notice statement, if we could add that to the MLI in the future, I think that would be a great way to streamline and include everything in one place for our beneficiaries.
And you're specifically talking the statement, not the notice, correct?
Both.
I'm sorry. That's an OCR question.
Okay.
I don't believe that, I'm not going to say that. I'm going to say it's an OCR question, and it has yet to be determined.
Yeah. Okay, great.
Okay.
If there's an opportunity to comment on that in the future, I think it'd be a great idea.
I really, and my gut tells me, and I'm sorry, but my gut tells me if it's the MLI, the only thing that should be on the MLI is the tagline.
That's correct.
Okay,
Per
so-
current guidance, correct.
Right. So I don't think that going forward, I don't think that the statement as well as the notice will be on the MLI. That's just my gut, but.
Fair enough.
Okay.
Thank you.
Okay, the next question that I have here says that large print is 18-point font only, or is that the standard that CMS uses? We understood large print to be between 14 and 18 point.
So you're right. The 18 point is what CMS uses, and there is no rule specific that says you must use 18 point. But I will share that Jim and myself and our small but mighty team of folks working on this stuff have done a lot of research. And pretty much everybody in the world agrees that 18 point font is large print. I think you might be a little challenged to argue that 2 points up from 12 to 14 is really increasing the size. Having said that, you're free to choose the size that works best for your customers. But if you go with something like 14, I think you're going to get a number of questions or requests for other things. So.
Okay.
There was a second part.
Yep, there is a second part. Where it says that plans should provide an alternate format in a timely manner, what is CMS's standard time frame for this?
Good question, and this will actually be one of the FAQs that we talked about making sure we get out to you. And we tried to touch a little bit on this on our presentation, but again, to summarize, there isn't a specific time frame. We're not saying that it must be 1 day or 24 hours or 48 hours or what have you, but you must keep in mind that the provision of information to individuals has to be timely in the sense that it should not interfere with their ability to enjoy the same rights, privileges, benefits, and protections as somebody who received that communication in a standard way. So using, again, the appeals process as an example, if an individual is told that they have 72 hours to take an action for an appeal, but it takes you 4 days to get something to them in Braille, and they've already missed that window, clearly you've disadvantaged that person. So you need to be timely in order to protect against such things, and you need to think about those time frames as you're thinking about how to get information into people's hands.
Okay. In a recent HPMS memo, CMS listed examples of significant communications and publications, suggesting there may be some exceptions. Can CMS please provide some specific examples of materials that would not require the non-discrimination statement and/or the translated non-English speaking disclaimers?
Actually, that's a decision that needs to come from OCR. As I said previously, they need to make the determination as to what is considered significant communications and publications. We just don't have it right now. OCR will release an FAQ, hopefully soon, and that can address some of these questions.
Okay, and I have one last question here. What should be provided with things like member confirmation of enrollment letters or grievance resolution letters? Are these considered significant small documents that only require the tagline and non-discrimination statement in the top 2 languages?
I'm going to go out on a limb here and say that our interpretation of small size documents are at 1 page or less. If you ask me in court, I'll say, no, I never said it. But I'm going to step out on the ledge and say our interpretation of small size is considered 1 page or less. Yeah, we'll see.
All right, that brings an end to the questions that I have for this group and all the groups. So please help me thank Randy, Jim, and Arlena.
Thank you.
All right, one last time to evaluate the session, the open Q&A session. If you would like to participate, go ahead and enter A and follow the instructions. Okay, if you would like to evaluate today's conference, we are going to bring up another polling slide, and you will go ahead and enter A into the in response to the question, I would like to complete the event survey, and you will click on that link just like you did before. So before I bring that up, I just want to say that if you did not participate in the polling today but would like to provide your feedback regarding today's event, a link to the event survey will be emailed to you. Please consider taking a few minutes to provide CMS with your feedback. Okay, if you do want to complete the event survey and you are actively involved in the polling with us today, go ahead and enter A, and it will give you a link to the event survey. And that about wraps things up for us today. I just have a couple more closing remarks, and that the first one is to obtain your CE credits for today's event. Please refer to page 19 in the conference guide. That will give you the information you need to obtain those credits. And second, CMS would like to thank our presenters for your time and dedication. We truly appreciate all the effort you put into today. And of course, the in-house and the web participants for your participation. Thank you to everybody, and have a wonderful evening.